I don't use that quite so much. I love it, but it's just very up and then back. It's a bit too quick, I think, for my liking. Once that central line is in, though, I relax. I think I've got so many more options available to me. So then I have sodium nitroprusside. We call it GTN, but it's a nitrate. And NORAD as well. But my first line for hypotension is what I was talking to you before, Sanjay, is metaraminol or aramine. You can administer it peripherally. It's very titratable. And we can take metaraminol to our recovery, and they are happy for us to run metaraminol in the recovery room, but they are not happy for us to run noradrenaline in the recovery room. So if I'm on noradrenaline, I have to stay with my patient until I either wean it off or I send them to ICU. And we are very resource poor with our ICUs. So while I'm sitting there with a patient on NORAD, we still have 3 other thyroids to do, or another adrenal and a parathyroid. Do you know what I mean? So time is of the essence for everybody. So yeah,
Thank you. Thanks a lot. Thanks a lot.
Yeah, I would like to ask you, what was the total surgical duration of the first case you have gone through?
The cons?
Yeah, the cons patient, yes.
The actual, what I call knives and forks in, was less than 60 minutes. I don't know, 55.
Because the patient was made prone, na? And patient was having high BMI, more than 40, I suppose.
I say to my team people, the positioning often takes almost as long as the case does. Not really, but it takes about 20 minutes to get it absolutely right. Face, brachial plexus, everything else. And with those big guys, just really getting their cushions and the padding right. So overall, the case took, I think it was about an hour and a half or similar. But the actual operating time was less than an hour.
And what method you use for providing analgesia during operation time and post-operative time also?
So paracetamol and paracoxib, an anti-inflammatory, and I run them on propofol and remifentanil, which is analgesic as well as everything else that it provides.
I think you gave subarachnoid block morphine in that case.
Oh, sorry.
In your presentation,
For the
I have, yeah.
For the open procedures, yes, he still had paracetamol and anti-inflammatory, but because he had a spinal, he didn't actually need a lot of intravenous analgesia at all. At the end of the case, I just gave him some intravenous oxycodone. We have oxycodone, but then started him on the patient-controlled analgesia device, the intravenous administration.
Means you have only used IV analgesic drugs for providing pain relief intraoperatively and postoperatively also.
Didn't give up opiate is that young man because of the spine.
Okay, thank you. Thank you.
Thank you, ma'am. We take a short tea break, and you're requested to reassemble in the hall by latest by 10:45. We have to start our next session.
Good morning, all. I'll request all to be seated. And on behalf of all the chairperson, I invite you to this session, which is focus on thyroid cancer. And first speaker in this session is Dr. Pallavi Prasad, who is additional professor in pathology, and she would be speaking on pathology of subtypes of PTC. Over to you, Pallavi.
Very good morning, everyone. Thank you, ma'am, and I welcome everybody to the topic which has been provided to me, and it is a slightly different topic than that we have been dealing so far in the conference. So, from a pathologist perspective, I shall be dealing with the variants of papillary thyroid carcinoma. And as we all know that it is the most common type of malignancy in thyroid, which can have varied morphology, either follicular, papillary, or solid. And it is characterized by a typical set of nuclear features. We all know that well. But then why should we know about the variants? Why for surgeons, it is particularly important. Firstly, because the variants, they guide the surgical extent. Secondly, it can help the surgeons to stratify the prognosis, that is, assess the risk of recurrence and how much aggressive the tumor is. Then there is also a molecular and morphologic implication for that. And the net result is, of course, the benefit of the patient in the form of tailored adjuvant therapy and follow-up. So the WHO latest edition in 2022, it gave us a number of variants of PTC, and I shall be covering them. The salient features I shall be covering one by one. So we all know that the conventional PTC is characterized very well by papillae, nuclear clearing, grooves, and pseudo-inclusions. Everybody knows that. So this is how a smear from PTC looks on cytology. It has papilloid fragments and is arranged in monolayered sheets. On high power, we can see the set of nuclear pseudo-inclusions, and on histology, we get nice papillae. Then we have the encapsulated variant. As the name implies, the tumor is enveloped by a thick fibrous capsule, which may or may not be infiltrated by the tumor. And then this is how it looks like. We have a papillary tumor, that is PTC, and it is rimmed by or covered by a thick capsule. And on high power, of course, it will show the nuclear features. Then it should be differentiated firstly from a follicular adenoma with papillary architecture, because follicular adenoma is also known to have a thick capsule, as we can see here in this image. But when we go into higher magnification, of course, the nuclear features would not be there. The second differential is that of a papillary hyperplastic nodule, which many times we see in cases of MNG or goiter. So these appear as benign papillary infoldings, but then again, there will be absence of nuclear features. Coming to the next entity, that is the infiltrative follicular variant. It, as the name implies, it has an exclusive follicular pattern, and it is of two types, either infiltrative or invasive encapsulated. But the behavior is more or less like that of classic PTC. And then how it looks like, we have these tumor cells, these follicular pattern tumor cells, which infiltrate into the benign appearing, the adjacent benign thyroid parenchyma. So this is the tumor, and we have fibrosis, and this is infiltrating into the adjacent thyroid. Then comes the oncocytic variant, in which we have very nice big cells with voluminous eosinophilic bright cytoplasm. And this variant, we label it as an oncocytic when more than 75% of the cells show oncocytic features. But however, no necrosis or mitosis is there. This oncocytic variant should be differentiated from the tall cell, because in this also we have large cells with abundant eosinophilic cytoplasm. Particularly, the tall cell variant has a very poor prognosis, so it is necessary to differentiate between the two. But in tall cell, what happens is the height is 3 times the width. That is the strict criterion to call it a tall cell. Then coming to the solid or trabecular variant. And it is a very rare variant, and initially it was reported in few children after the Chernobyl accident. So the tumor is arranged in solids trabeculae or nests. And how these nests form? They are formed because again we have fine septa which are dividing the tumor into multiple nodules. And to label it as a solid variant, again the cutoff here is more than half of the tumor. That should show features of solid pattern. And this variant should be differentiated from aggressive high-grade follicular carcinomas because these can also show a nesting pattern. But the difference lies in that the high-grade variants not usually, but always they have a necrosis and very brisk or frequent mitosis. Then comes the very well-known but disastrous entity, that is the tall cell variant, which is usually seen in elderly patients. And as you can see in the lower image, the height of the cell is more than or equal to 3 times the width of the cell. So that is the characteristic morphology, and it resembles a tram track appearance because the follicles are elongated and they're compactly arranged together. So they form a sort of tram track-like appearance. And it should be differentiated, like I mentioned previously, the closed differential is an oncocytic lesion. So oncocytic PTC comes in the differential along with Warden's-like PTC and Hurdle cell tumors also. The tall cell variant PTCs are usually large, but they are characterized by extrathyroidal extension, and recurrences along with tracheal invasion is very common. And they are characterized by brisk mitosis and vascular invasion. So picking up this variant is particularly important for us as well. Then comes the columnar variant. Again, these two are slightly similar entities. So in columnar, what happens is, again, this is a very hypercellular and crowded tumor, and the follicles are elongated, but we also see fine papillae running in between, which was not seen in case of tall cell. There we saw elongated follicles. Here we have nice papillae running in between. And the cells, the architecture can be, we have papillae, then we can see also appreciate these follicles also. So it is an admixture of both of them. The nuclei, they show stratification. That is, there is difference in the layering of the nuclei in the cells, and they are characterized by presence of subnuclear vacuums. So in a way, it reminds us of the secretory endometrium. So of course, the differential will come as firstly the tall cell PTC, then any high-grade follicular derived thyroid carcinoma, metastasis, especially endometrium or colorectal. So in case of metastasis, we can take the help of IHC to know whether it is a thyroid lesion or a metastatic lesion. And prognosis depends on the encapsulation and the infiltrative status. Again, this columnar variant is very ominous. It is characterized by distant metastasis. Then we have the hobnail variant. This is very, very rare. I particularly have not encountered this so far, but it is very aggressive, and more than 30% cells of the tumor should be hobnail in appearance. So what is meant by hobnail? See, here we have a nice papillary or micropapillary architecture. So this is a complex, all these are micropapillae formations, and the cells, they show a hobnail appearance, that is sort of snouting or outpouching from the cell surface, they bulge into the lumen. And the nuclear features of PTC will be there. And by default, this is also a high-grade malignancy. And this hobnail variant, to give the diagnosis, there should be extensive sampling because it can be present like associated finding in other tumors also. Again, this is an aggressive variant and is characterized by vascular invasion and extrathyroidal invasion, and distant metastasis is known. That is, it can be present initially or later it may develop. Then coming to the clear cell variant. Clear cell changes by default are a non-specific finding in thyroid lesions. But when do we label a cell as clear cell? When we have a large number of clear cells which are growing in papillae or solid sheets. So this is how a clear cell variant of PTC looks like. And then for metastasis, it should be differentiated from, even though it is rare, but it should be differentiated from metastatic clear cell RCC. Like this image is very typical of clear cell RCC also. So that is our first differential. Then we should differentiate it from intrathyroidal parathyroid tumors, because parathyroid tumors are known to contain clear cells. Sorry. And thirdly, we should differentiate it from medullary thyroid carcinoma. Again, we have to use the help of respective IHC markers. Then coming to the spindle cell variants, the spindle cells, in this case, the tumor is exclusively made up of spindle cells in around more than 50% of the cells. And we have spindly cells arranged here, but they are more or less bland. We don't find any mitosis or necrosis. And for differentials, it should be differentiated from other malignancies which have spindle cells like anaplastic, medullary, or settle, the new entity of settle. And again, morphologically, it is challenging, but we can differentiate. Then we have PTC with fibromatosis or fasciitis or desmoid type stroma, in which we have abundant cellular stroma, but we also have an epithelial element. which can be in the form of either cords, tubules, or papillae, and the stromal element is cellular, or it can also show myxoid or collagenous changes. The epithelial component will be positive for cytokeratin, but stromal will express your mesenchymal markers. Then this renal cell variants also are aggressive. They have high risk of local infiltration, lymph node metastasis, and high risk of recurrence. Then coming to diffuse sclerosing variant, this is particularly seen in young females, and it has certain cardinal features like we have lot of fibrosis in the gland, this encircled findings. These are the psammoma bodies. Then we have a lot of background chronic lymphocytic infiltrate, and then squamous metaplasia may also be seen. And this again has a poorer prognosis, but also, I would like to add, we also get there are chances of lymphovascular emboli is almost invariably present in DSV. Then in Warden's-like variant, it resembles the Warden-like tumor of the salivary gland, and it develops on a background of chronic lymphocytic or Hashimoto's thyroiditis. In this, what happens is we have cells, we have nice papillae, which are lined by oncocytic cells, which I have described earlier, and then we have dense lymphocytic infiltrate. So this is how a Warden's variant looks like. But prognosis is more or less, even though it is very nice looking for us, but the prognosis is similar to that of classic PTCs. So to summarize, the learning point is that not all PTCs are equal, as recognizing these variants guide tailored therapy. The aggressive variants, of course, they warrant an aggressive management, whereas the favorable ones, if we diagnose those, we can avoid over-treatment. And the key is a proper communication between the pathologist and surgeon. So this is just to complete, for the completion of my topic, a list of mutation which has been known in the various variants. And so summarizing all of which I have covered so far, we have the classic variant, then the encapsulated PTC, which has an excellent prognosis. Also the Warden's-like variant, which has a good prognosis. What entities lie similar to the classic variants? They are the follicular PTCs and the clear cell and the spindle cells. Now, summarizing the aggressive variants, we have solid, PTC, hobnail, diffuse sclerosing, tall cell, and columnar cell. All these are the notorious or aggressive entities. So, the point is that microscopy may help in guiding the management, and we should take it into account while reporting any tumor of any papillary thyroid carcinoma, and not all PTCs behave the same. So knowing the variant can change surgical planning, prognosis, and long-term management. So thank you very much. I hope I tried to summarize. Actually, it's a very vast topic, but I just quickly try to summarize the salient features.
Thank you, Dr. Pallavi. Uh, would you like to comment on why there is so much chopping and changing happening with endocrine tumors, and more specifically with thyroid cancers every now and then, unlike many other solid tumors which have a very settled kind of histological classifications? Unlike majority of other solid tumors, we are more dependent on architectural features or cellular features in thyroid cancers. Others have more replicable objective features, some scoring systems, for example. Would you like to comment on that?
Sir, I don't have, I'm not able to answer your question like why particularly in PTC, but I think that was the on the basis of various studies we noted that these particular morphologies they correlated with poorer prognosis. And in fact, sir, actually we also like while reporting, when we also report a case of tall cell, and when it's discussed in our morning classes also, or we see in the discharge summary also, that always invariably shows some degree of aggressiveness. Similarly, most of the entities which I have discussed, like hobnail and columnar, that we haven't encountered, like I haven't encountered so far. But I feel that more or less in this case, the prognosis depends on the morphology a lot. The exact reasons are even I'll have to go through.
Any comments or questions from anyone?
One question, I'm not aware, but do you know if there's been an attempt at genetic mutation profiling to match the variant?
Yes, sir. different variants they have. There has been, even in WHO, they have mentioned, for the last second or third last slide I showed for completion. So the aggressive variants, if I can open that again, they are characterized by a particular set of mutation. And that in turn, so those variants we can go for targeted therapy.
Want to use the projection?
Like, so the well-known in classical PTC, of course, we have BRAF mutation, but coming to the aggressive variants like solid or diffuse sclerosing, we have red PTC mutations. And then TERT mutation that is seen in case of tall cell variant. TERT is the second one that is implicated after BRAF. So this mutations, they are there, they have been mentioned, and they also help in guiding the therapy.
We move ahead. The next talk in this session is on risk stratification, and this will be delivered by Professor Divya Dahiya. Dr. Dahiya is the faculty in charge of breast and endocrine unit at the PGI Chandigarh. Welcome.
Good morning, everyone. First of all, I would like to thank organizing committee for their kind invite to this prestigious meeting. And I will be speaking upon dynamic risk stratification. As we know, clinical behavior of differentiated thyroid cancers varies between indolent, slowly progressing tumor to highly aggressive tumor. Therefore, it is important to avoid over-treatment for low-risk cancers. And modern management of differentiated thyroid cancer requires individualized care plan that tailor the intensity of therapy and follow-up to the estimated risk of recurrence and disease-specific mortality for each patient. Current ATA guidelines has suggested clinical decision-making based on the thyroid cancer, then assessment of the risk, treatment in the form of surgery or active surveillance, and then reassessment of the response of the treatment for the patient. And after intervention, the risk of recurrence was estimated as low, low to intermediate, intermediate to high, and high grade in various subtypes of the differentiated thyroid cancer. And it was recommended to use histological features of the tumor along with the AGCC staging, postoperative imaging, and serum TG levels for risk stratification. Molecular profiling of histological specimen is not recommended routinely. And this risk stratification after surgery should be performed within 3 months. And the major difference in 2025 and 2015 guidelines was that the microscopic extrathyroidal extension, which has upstaged the tumors, was excluded from 2025. And the response criteria after receiving intervention was categorized as excellent response, indeterminate response, biochemically incomplete response, and structurally incomplete response based on the TG levels and imaging findings. And the patients who achieved excellent or indeterminate response after the intervention were not advised to have TSH suppression. So the response criteria should be used to categorize the response to the surgery before deciding for any additional treatment like radioactive iodine to be given or not to be given. So the recommendation for radioactive iodine therapy after thyroidectomy was in the patient who are in the low risk category, they need not to have remnant ablation. However, the patient in the intermediate, low or high group or high risk category should receive remnant ablation or adjuvant therapy. So after receiving radioactive ablation or not advising radioactive ablation in any patient,
Next assessment should be performed at 6 to 12 months after the initial therapy by using clinical examination, imaging in the form of high-resolution ultrasound and TG levels. So the dynamic risk stratification is a continuous reassessment of post-treatment response, which represents a paradigm shift from a one-size-fits-all treatment approach to individualized risk-adapted management as new data will be available on follow-up. And it integrates initial clinicopathological risk with the patient's response to therapy. And the goal of dynamic risk assessment is to avoid overtreatment and intensive follow-up for the patients who have good prognosis, and to focus the therapeutic efforts on patients with a worse prognosis who require more aggressive management. It also provides real-time risk assessment at any point in the patient's disease course, and it also helps to distinguish actionable findings which need immediate intervention to non-actionable findings which can very well be kept on observation. So the ATA guidelines define 4 response categories when the patient is on follow-up as excellent response, biochemical incomplete response, indeterminate, and structurally incomplete response. So if we see this figure, the patient who has achieved excellent response after initial treatment, but having low risk features, the risk of recurrence on follow-up is less than 2%. However, the patient who had excellent response, but they have high risk features, the risk of recurrence is as high as 15%, and this risk increases based on whether the patient had indeterminate response, biochemically incomplete, or structurally incomplete response. So the ATA 2025 updates have included more sensitive TG assays. TG trend should be monitored rather than a one fixed value. Functional imaging and molecular marker as and when required should be included in the further diagnosis. And long-term TSH suppression was not suggested for patients who had low or intermediate risk of disease, who had no evidence of biochemical or structural recurrence. And risk of subclinical thyrotoxicosis versus benefit of TSH suppression and TSH roles should be re-evaluated during every visit. And aggressive suppression is no more recommended as it does not increase the progression-free or disease-free survival for these patients. And how frequently the TG measurement should be done, the specific assays to be used, and it should be the serial measurement. And it is recommended that the patient who had total thyroidectomy, preferably after radioactive ablation, or the patient who falls into the intermediate and high risk category, serial monitoring of TG is recommended at 6 to 12 months of time. So can we de-escalate, and what patients we can de-escalate the management on follow-up? So the patient who underwent hemithyroidectomy, the screening ultrasound should be performed 1 to 3 years, and if they are doing well till 5 to 8 years, then ultrasonographic examination from the screening can be omitted for this set of patients. And the patient who has undergone total thyroidectomy with or without radioiodine ablation, where TGs are undetected, ultrasound examination can be omitted after 5 to 8 years of follow-up. This is for the patient who has achieved excellent response after the initial intervention. And TG monitoring can further be omitted for this set of patients after 15 years of undetectable levels. So the whole body scan was not recommended for the patients who fall into the low risk category. However, it is advisable for the patient for the intermediate to high risk category whenever it is required on the follow-up. So the ongoing risk stratification, when used in combination with the initial risk of recurrence, it allows the clinician to provide individualized management recommendation while risk estimates evolve over the time. And the Patients who have persistent disease or recurrent disease, they should be re-evaluated for the treatment decision, whether any kind of intervention is required for them or only surveillance is okay with TG and PG antibody levels. So intervention, preferably best option is always the surgery if we can resect the disease. But in the patients where resection is not possible, then local ablation therapy by ethanol ablation or radiofrequency or the use of the external beam radiotherapy is recommended, but that is like the conditional recommendation based on the patient disease, local disease. All the patients so it is the dynamic risk stratification start from the initial risk assessment, then treatment, follow-up if required, retreatment, and in the excellent response group, the follow-up after the 15 years, we can stop monitoring these patients. And major change from 88-2025 was it has retained the principle, but it has refined the criteria. And however, the original concept for dynamic risk stratification, it stays the same. And the clinical application was TSH suppression intensity was decreased, de-escalation was advised, and risk-adapted surveillance was offered for the patients who falls into the intermediate to high grade. So the take-home message from today's talk is that it is an ongoing individualized evidence-based post-treatment response to therapy throughout the journey of thyroid cancer. It revises the risk recurrence at 6 to 24 months and thereafter. Thank you.
Any questions from the panel or the floor? Yeah. So, are you using dynamic risk stratification now routinely in practice? And you find that it helps in specific ways?
Sir, actually, for the radioiodine ablation, we are not doing for the patients who are in the low risk categories, or like we are not doing the check scans also after 4 to 6 weeks of surgery. But for the patients who are in the high risk category or like the intermediate risk group, in those we always do the uptake scan after 6 weeks of the surgery. And depending on the findings, we decide whether to ablate or not.
Very good. Yeah. So I think that has actually brought down the number of unnecessary iodine scans that are being done there. That's one big change. And long-term suppression also, which used to be given routinely, we can reassess and then reduce the suppression.
The high suppression where the TSH is practically undetectable. So we are keeping it as like 0.05 maximum, not more than that.
Sure.
In continuation to Dr. Paul's question, like if you send a patient of intermediate risk for ablation, that has been taken care of. There is no uptake in subsequent scans. So do you follow up these? I'm talking about intermediate risk patient. How long you follow up with the scan, or you are happy with only TG?
Doesn't show any, and then we don't ablate, and we still do the TG, anti-TG levels after 6 months of the initial treatment. If they are okay, we don't repeat the check scan. But if there is any variation in the TG or anti-TG levels, only then we repeat the check scan for those patients. And if we have ablated, then definitely we do a check scan after 6 months. And based on that finding, same.
Usually our nuclear medicine colleague would insist for at least 2 negative radioiodine scan in this scenario.
But for last 1 year, we have changed the policy to the one we have.
Thank you. If there are no more questions, I will call upon stage Professor M.J. Paul. He needs no introduction. and he would be speaking on locally advanced thyroid cancer. Over to you, Paul.
Thank you. This was presented last year, so sorry if it's a repeat for some of you. So we are dealing with the locally advanced thyroid cancers in quite a few percentage. I think the major centers in India, we do see this often. From the literature, we can see from a meta-analysis of 18 series, they saw 6% of cases had locally advanced disease with aerodigestive tract invasion. So if we look at it, why it's so important, it's often one of the causes of death in 35% by itself, and in association with metastasis, another 28. So it's involved in 63% of deaths. So local invasion is a very important area that we need to look at carefully. So we can divide it just for convenience into a central axis, lateral, mediastinal invasion. And the structures involved, anterior muscle and strap, and the important structures, trachea, recurrent laryngeal nerve, IJV, then the esophagus, pharynx, the larynx, and the carotid artery and vagus as the least involved. So this also changes according to the type of tumor. So from 13% in differentiated, almost 100% in anaplastic. So the management principles are basically, it's based on life expectancy. And we must focus on short-term maintenance of speech, breathing, and swallowing functions. And the long-term goal is of loco-regional disease control. External beam radiation and non-surgical ablative options also have come in. These are the changing system. The main change that has occurred earlier, we used to use chemoradiation either as additional, or we used to use it even upfront chemoradiation, neoadjuvant. But now TKI has taken over the role, and it's coming very strongly, and it's really been a game changer. I think that's the main message that we need. And the decision needs to be in MDT settings. So just in case to share, this is a locally advanced thyroid cancer. It was already recurrent, and this had involved the skin directly at presentation. It was classified as one of these high-grade differentiated tumors. The original biopsy was PTC done at another center. So you can see this is the effect of TKI. Because the tumor is in the skin, when we use the TKI, the skin necrosed completely, and she was left with an ulcer, fortunately clean. But when she came after 6 months, this was the final effect, skin and muscle completely infiltrated. And we removed the entire territory and used a partial sternotomy as well to get access inferiorly. That is the carotid. I'll come back to that later. So the skin closure was done with a pectoral muscle myocutaneous flap. And she is now completed 2.5 years, now has developed metastasis in the skull. And in her part of the world is finding it difficult to get ablation, unfortunately. So we're still trying to chase down some follow-up treatment. Another one of these rare cases which come with extreme enlargement, basically papillary cancer, solid cystic, involving the skin, been taking all sorts of indigenous therapies. But you can achieve a reasonably good result by removing all the involved structures. Fortunately, a lot of the muscle is just pushed and not infiltrated. So the function as well was preserved. So just, it's mostly a pictorial presentation. It's almost like a triple combined tumor. So here's the main part of the skin involvement, which was taken off by an elliptical incision. And then we fashioned the muscle and skin to get a reasonable result at the end. So he's also doing well post-op. This is a rare case where we had operated several years ago, and the patient came back. You can see the scar of the previous surgery with skin metastasis only. So obviously there was a seeding into the skin. The only time I've seen this large presentation, usually they come with fine skin nodules with extensive lymph node mets. But this is large cystic tumor in the skin, and we just excise it. This is another rare case where patient was given radiation post aggressive surgery almost 35 years ago now. So that is the time when we're using the cobalt without much discrimination, very heavy dose of radiation. You can see the effects on the neck. and came 15 years that, so 20 years ago, with this sarcoma. So this is very rare. The only case I've seen a post-radiation sarcoma in the neck following surgery for advanced thyroid cancer. She was in follow-up for 2 years, was doing well. But after that, it's known to behave aggressively. So after that, we lost follow-up. This is a IJV invasion. I think this we do see often. So superficially, if it's invading the adventitia but has not gone through the full thickness of the wall, we just do adventitial dissection, and you can see that layer peels off, and usually you can preserve it. If it's a full thickness involvement here, then you need to, you can do a partial resection of the wall and reconstruct the IJV for flow post-operatively. Here you can see that the tumor is there, the white patch, and there's a defect in the IJV which can be easily repaired. So most often you can get away with this. Esophageal invasion is another interesting area. So often it's just muscle only. So when you see the tumor invading the esophageal wall and you don't have a significant history of dysphagia, has not been assessed, CT has not shown any concern of esophageal full thickness involvement, then at surgery, you can dissect the muscle off into the submucosal component and just close the muscle over. Most often that's what happens. Now, rarely we do have mucosal involvement of the esophagus, and then we need to do a full thickness resection, close in layers, keep an NG tube for 5 days and a drainage as well. Make sure you've got healing and then take it out. Again, this usually is not a problem. I've had a very rare case where, again, it was a recurrent tumor from elsewhere. We discussed radiology. Unfortunately, they missed the esophageal involvement. Even the patient had dysphagia. So at surgery, I went in confidently, took the whole tumor out, and then found I had 2 ends of the esophagus at the end of the procedure. But fortunately, we could mobilize the esophagus on both sides, do a primary reconstruction, and patient was okay. So after that, not much fear of esophagus. So here is the tracheal invasion. I think this is the sort of poster boy of local invasion. So the Shin and Grillo classification, we're all familiar with. So it's a superficial stage, then just a shave is sufficient. When there is intraluminal disease, no doubt resection is required. So when it's stage 2, deep, where it's going just between the cartilage, that's when it becomes a little leafy. So again, most often, if you can get the gross tumor out, shaving is enough, and we may have to give radiation post-op. This is a case, deep stage 2, and underwent a shave and had post-op radiation. And this was a differentiated thyroid cancer. This is 12 years following the radiation. Was a bus driver, and he's fully operational, no restriction, except for the hardness of the radiation doing well. This is a tracheal intraluminal tumor. You can see it bulging into the lumen, and the cartilage is fully involved. So 58-year-old, recent noisy breathing, came with a 3-centimeter hard fixed lump. So there you can see the trachea has been resected with the ET tube visualized, and the tumor bulging into the trachea. So after full thickness resection, that's a 3-centimeter. So usual, what we've seen is up to 4 centimeters, there's no problem in mobilizing both ends and getting it together. So, and very rarely would it involve more than 4 centimeters. So here's after the repair, just an interrupted absorbable with vital. And these patients do very well. So the methods of mobilization are described as suprahyoid Montgomery, which I've done once, and I don't like it. It produces a lot of edema and pain, so I've given up Montgomery's after one. The infrahyoid, below hyoid, just cut the sternohyoid muscle, and the larynx actually drops. So not the laryngeal muscle that is between the hyoid and the larynx. That is the DDO drop, infrahyoid release, and you can get about 2 centimeters of drop with that. And of course, mobilization of the inferior trachea will give you another 2 centimeters, and so usually 4 centimeters is not a problem. Now, if you are stuck, say if you have a oblique defect and then there's one component which is not coming together, you can use autologous cartilage from the rib. So one of my students actually called me once saying, I have a case and we've got a defect, we can't close it fully. So fortunately, her husband is a thoracic surgeon, so he stepped in took out cartilage, put it in, and he even used some porcine membrane and glue to put it together, and they managed to get the bridge across. Rarely you may need a permanent tracheostomy if you have to take out the entire larynx. So we'll come to that. So this is the Montgomery superficial drop on the, what's showing that? Okay. So here you cut the muscle above the hyoid. And this is the thyrohyoid muscle. If you need to do the Dido drop, you just cut this, very simple, and the larynx will come down quite a bit, 2 centimeters. Do you need to restrict? There's another learning case we went through. Now, classically, surgeons who used to do the tracheal dissections were done after post long-term intubation, and they used to get this stenosis. So they used to stitch the chin to the chest to prevent traction. And then from the advice of another colleague, we stopped stitching, saying actually it's not necessary. We've not done that for the last 15 cases and no problems. This is the endoscopic view before and after tracheal resection. You can see the, this is from a paper by Lin in 2014. So this is another case, choking of airways, stridor, resected, had post-op EBR. The patient already had lung metastasis at presentation. So this is one of the ways we say sometimes you can alter the manner of death. At least choking will not be the case of death. The patient was on sorafenib, survived 5 years, then succumbed to progressive lung disease. At that time, we didn't have any other options except sorafenib, but had 5 years of reasonable quality of life. This is a laryngectomy case where you can see the tumor has gone into the larynx, involved the cord. So here there's no option. We had to take the larynx out. But even though the patient had a laryngectomy and was using a artificial voice, was still happy with her outcome. So that's a publication of series of 22 cases. And I must say they have done pretty well. So here's a rare case where we took out the whole tumor and there was tumor going into the venous channel into the prevertebral plexus. So that stump you can see. And we couldn't access because the risk of bleeding was too high. So we left that tumor and radiated it. This is a case of carotid invasion. You can see complete 360 encasement, normally not operable. But what we realized is you can see in the longitudinal as well, there is no intraluminal extension. Then rarely as these cases can actually be completely divided open like a book, and again subadventitial dissection. That's the carotid after dissection removal of the tumor. Young boy who has done very well, again completed 12 years since that operation and was reported by Sabha when he was there. So this is where we had to resect. The first case that I presented with the skin involvement also had full thickness carotid invasion. So we had to resect it and do a venous reconstruction from the saphenous. That is very rare. Only 2 or 3 cases will come like that. RLN invasion is another area. So the recommendations are either leave microscopic disease or gross disease if it's functioning. And you can use iodine in differentiated thyroid cancers to still get control. You may need radiation if it is a aggressive variant or a poorly differentiated. We've attempted some ANSA RLN anastomosis when it's involved, but mixed results. I'll just skip this. It's another case of, this is one case where we did preoperative embolize. It's a massive papillary, the whole thing is papillary solid tumor. Again, somebody who's been long-term indigenous therapy. So we very vascular solid. So embolized preoperatively, that was a good result. So managed to get it out. He is also very rare case, which had no metastasis, but came back with axillary node, skin metastasis, all resectable, and he's gone on for the last till 5 years ago, he was with us on follow-up. Now, the role of adjuvant EBRT to the neck for high-risk local recurrence, micro and macroscopic disease, we do radiate and we err on the side of radiation. Percutaneous ethanol injection for small nodes that may be residual, that can be done. Progressive disease in medullary thyroid cancer, we have new drugs coming up. This is a case of sorafenib in the old days. You can see how the tumor has regressed. So what we find is tumor become less vascular, less invasive, and they're much more resectable after TKI therapy. This is lenvatinib, 6 months again in MTC given and then operated. So a lot of these cases, DTC lenvatinib. So Dr. Pooja and group put together multi-institutional and showed the effect of tyrosine kinase inhibitors in downstaging and palliation with advanced differentiated thyroid cancer. This is one of those cases from externally, you can see how it has shrunk down. So the last slide, just the trials that are available with this game changer, which is use of TKIs in different cancers. Thank you very much.
Thank you, Dr. Paul. An excellent case series of very difficult cases to treat. I'm sure there would be comments and questions. Oh, yeah.
Thank you for an excellent talk. Thank you. With your tracheal resections, you say no stitch, but do you use a hard collar, or what advice do you give to patients post-operatively?
ICU was okay. I mean, fortunately, they were okay with us not doing it. So what we find actually is you just have to be, the usual care you take while you transfer patients. And the patient usually has a protective spasm. I mean, because when they're awake, they've had a major operation, they're going to be like that. So we found this stitch on the sternum very difficult for them.
It would be horrendous, I think.
And this one of our colleagues who was in ENT had done it with for children with stenosis, and then she was working in a Switzerland group who were actually one of the world leaders, and they had come to our place and said they'd stopped stitching, and they didn't have a problem. So based on their experience, we said, okay, we should try it, and we gave it up in the last 15 cases, no problem. So.
We don't stitch, but we do put a hard collar.
Okay. So no collar, no stitch, they're all fine. Yeah.
Sir, one question. Sir,
Yes.
nice presentation, sir. So just I want to know the extent of imaging before going to the surgery. You told that that the CT scan is sufficient. You go for the further imaging for going for surgery.
Yeah, a good contrast CT is what is really required. In rare instances, we may add on an MRI if we think we need, especially for mediastinal vascular involvement. Otherwise, yeah, a good CT is pretty much.
So how do you rule out the metastasis, like in big case of PTC in the neck? So do you rule out the metastasis before going to the surgery, or just local?
Yeah,
CT
I know the
scan?
standard with the CT, we do a neck and thorax. So basically, we pick up the major mets either in the lung, liver, bones. So yeah, as I said, the first case that we did actually had lung mets at presentation, but because she was already in early strider, we counseled her and said it's better we get this out because we know how long you won't live much with this.
Okay.
But at least with the lung met, she went on for 5 years with sorafenib, and so they were very happy the family.
So would you go for the any molecular analysis before starting this TKI, or just start TKI?
Yes, now this we do that to targeted therapy. We do the molecular analysis to see what the mutations are before deciding.
So you're advised to go in all the patients before starting the TKI.
Yes.
And third thing is that would you advise for youngsters and discuss in the MDT before going to the surgical procedure, or involving the multidisciplinary team like vascular surgeon, plastic surgeon, head and neck surgeon, or you just go alone and operate these patients?
Yeah, no, so the decision is made with the MDT. So because the oncologists are involved with the TKI, the radiation therapists have to know post-op, they're usually involved. And then whichever specialty is required, we just pull them in at the time of surgery. They're quite used to it now. So we'll get the vascular team if it's carotid. The thoracic guys will come if it's a mediastinal issue. But these are the two main ones.
So you not discuss before and planning before. So just whenever it is required, you just call them and operate. Thank you, sir. Any questions?
Thank you very much. Are you a question? Okay.
anastomosis, when do you extubate your patients? Do you keep them on endotracheal tubes or?
Preferably on table. The best is to extubate immediately. That's what we found. The rare case where you've had a prolonged surgery, the anesthetist has concerns about reversal, then we just keep them overnight and take it out the next morning. But 90% are extubated on table.
On table. Okay. Thank you.
So,
One last.
yeah. So in your personal experience, the CT scan, the images, they overestimate the local infiltration or underestimate?
Yeah, usually over. I mean, with CT, we know usual overestimation. So, like the carotid, for instance, I mean, most people, in fact, the patient was seen at another center and they said inoperable and sent home. But when we did the detailed assessment, we could see that the lining of the carotid was clean on the internal aspect. And that's something I think surgeons tend to back out of, but there are at least 3 or 4 carotids like that. We've done a 360 excision, 360 encasement. So you can assess, but always have the vascular surgeon stand by. So for a reconstruction if required.
So we are better off taking chances and the risk too, or get scared and leave it to TKIs these days, because what we have seen is when TKIs have come, we tend to give up on these aggressive surgeries and put them on TKIs. And when then we re-explore them, actually the infiltration hasn't really gone away.
Okay, one last question. We need to move on.
Sir, regarding Shin 4 and if it is more than 4 centimeter or 4 tracheal ring involvement. So any experience in endobronchial debulking with thyroidectomy versus
that was
TKI?
the standard before we started.
Versus TKI.
Oh,
Because TKI, some say that TKI can also have some sort of
bleeding and
fistula
position has been described. Yes.
So that is one thing. Second thing is regarding tracheal anastomosis, any role of ICG in determining the vascularity while anastomosis?
Okay. No, the trachea usually vascularity is not a problem. You just have to be careful with posterolateral supply. So when we mobilize, it's only anterolateral mobilization. So if your posterolateral is intact, we've not had a problem with the ischemia of the trachea. So I don't think we need any adjunct. But yes, so traditionally they used to actually just do internal debulking of these tumors to preserve the airway. Then we started doing the resections. Now, as you know, TKI has been associated with fistula formation. So if it's resectable, I would say go upfront resect. But if you think invasion is a problem in carotid, then a course of TKI before surgery is also a good idea.
Thank you, Dr. Paul. So we go to the last talk in this session. This will be delivered by Dr. Christine O'Neill from Newcastle, Australia. We've heard her yesterday. Dr. O'Neill is the current president of ANZ Endocrine Surgeons, and Dr. O'Neill would be speaking on patient-centered care in thyroid cancer.
Thank you again. What I'm going to present now is actually the research largely that we've done. And it's one of my favorite things to get up and talk about, not other things, but actually the research that we've presented and put together. It's going to be a fairly quick ride through quite a lot of papers though. So we've actually had a great lot of presentations this morning and have really nicely demonstrated the changing landscape in thyroid cancer, where we've got the spectrum of quite severe disease that needs quite aggressive treatment. But the majority that we see certainly is low-risk disease and quite a lot of what's probably overdiagnosed disease. So they estimate that up to 70% of thyroid cancers currently diagnosed in Australia are overdiagnosed. And a reference I found suggested perhaps that figure was 50% in India. So guidelines are driving de-escalation of treatment with less surgery and less radioactive iodine for those with low-risk disease. But the other side of the equation is we need to know what happens to our patients so that we can help them to live better and not just to live longer. I first became interested in this when a US surgeon came to our National Australian meeting and presented his data on quality of life outcomes. And if you look at these graphs, you can see these are quality of life outcomes for thyroid cancer patients in the black, and they're worse than patients with breast cancer or colon cancer. And that didn't really make a lot of sense to me for a disease with a much better prognosis. So I went looking for Australian data and I found a desert, but there's a lot of desert in Australia. So we tried to fill the desert. We did the first quantitative study on quality of life in thyroid cancer survivors, and we chose long-term survivors, compared patients with thyroid cancer who'd had total thyroidectomy and radioactive iodine to patients who'd just had total thyroidectomy. And this was before the era of de-escalation of surgery. We've already talked about our MDT context, but we're able to include in these sorts of studies patients from all sorts of different demographic and geographical areas. I won't go into the paper in detail, but we were pretty pleased that in summary, overall quality of life seemed to be good, but there were some issues raised around fear of cancer, fear of future tests, ongoing issues with social functioning, even 5 years post-diagnosis. But it was also our first foray into this type of behavioural science research, and we made a lot of mistakes, to be honest, in our methodology and learnt from those moving forward. So on the basis of that, we then developed this prospective mixed method study looking at thyroid cancer survivors, and we've used a lot of validated instruments for this. SF12 is a generic tool, a shorter version of SF36. We used EORTC QOL, which is a generic tool for any cancer survivor. At the time we started, there were only 2 thyroid cancer disease-specific tools available, which were City of Hope and ThyCUP. There is now a third, which is Thy34. We used a specific fear of cancer recurrence scale called Assessment of Survivor Concern Scale and a financial toxicity scale. We asked these surveys repeatedly at 3-month intervals over the first 12 months following diagnosis. We recruited every single person with new thyroid cancer, unless they had anaplastic cancer or micropapillary thyroid cancer without adverse features. We had to exclude a few people who didn't have the capacity to answer the surveys either for language or cognitive reasons. We started in early 2020 and 2 months later went down into lockdown, had to completely reevaluate our recruitment strategies. It was actually a naturalistic opportunity to actually improve our recruitment because we'd built that up on what international studies had done, but it actually didn't really work well in our practice. So having looked at all of that, we restarted in June 2021 and collected data for 2.5 years. We ended up with 110 patients completing baseline surveys, which is a 60% response rate, which for this sort of research is actually pretty good. We learn a lot on the job about what to do and what not to do in this type of research. One of the most interesting things is we also asked patients how easy it was to complete the surveys and how comprehensively they felt those surveys measured their quality of life. And what's interesting in this is that although most patients found the surveys relatively easy to complete, for the generic surveys, only 40% of patients thought that the surveys actually explained their quality of life. And even for the disease-specific surveys that are supposed to be written specifically for patients with thyroid cancer, only 50 to 55% of patients felt that these surveys actually covered all the areas of quality of life issues for them. These are the results of this big prospective study, which have been accepted and published online in thyroid only within the last couple of months. The key finding is in SF12 that our patients have inferior quality of life compared to population norms, even 12 months after surgery. And so if you unpack these graphs, the black line is the normative population data, and these blue lines, the first one is a physical score and the second is the mental score. So although it's pleasing to see that they improve over 12 months, our patients are not returning to normal pre-quality of life. There's a lot of individual variation, so the blue lines are the means and the orange lines are individual variations. So you can see there's vast variation in that, which is a message in itself. In terms of specific symptoms, because the generic surveys really miss a lot of the specific symptoms that are relevant to our thyroid cancer patients, we were pleased to see that voice and scar got significantly better over 12 months, but some scales actually got worse. So patients actually had worse symptoms over 12 months in things like muscle and joint pain, feeling slowed down, cognitive issues, and irritated eyes and skin, even in those who didn't get radioactive iodine. And again, individual variation was marked. This is the assessment of survivor concern scale. The lowest score you can achieve on this scale is 5, but any scale above 10 really shows a reasonable degree of fear of cancer recurrence. And a lot of patients reported that, and it really didn't get that much better over the 12 months. Fear of cancer recurrence is a very important driver, and we've done some independent research separately on this along the time as well. We did a discrete choice experiment looking at low-risk thyroid cancer. So we asked a lot of patients a hypothetical scenario of a 1 centimetre thyroid cancer. We gave them all the different options of voice change, thyroxine requirements, calcium requirements, risk of cancer coming back. And we gave them, you basically vary around the percentages and give them different options and work out where the levels where they start to change their decisions between what are active surveillance hemithyroidectomy and total thyroidectomy. But in this study were labelled as options A, B, and C. So patients didn't quite know at the time which they were getting, which they were choosing. What we showed in this is that if you kept those risk factors and recurrence factors at the median levels for all patients in a 1 centimetre thyroid cancer, 50% of patients chose active surveillance, which is not what we practice. That's a really interesting finding. Needs a little bit more unpacking, but shows that patients are actually more willing to accept surveillance than perhaps their clinicians are. When you unpack the reasons for treatment, the risk of cancer recurrence is the biggest driver towards choice. And if you dial that up or down, patients will choose more aggressive treatment options. The second biggest driver is voice change, particularly when you're going towards a total thyroidectomy. We've also done some qualitative work along the way. And just to explain qualitative work, because surgeons often dismiss it as being non-scientific, the way I like to describe it is that if you only ask survey questions, you assume that we know all the right questions to ask. Whereas you need to allow a patient to voice their concerns in their own context or in their own way to truly understand the full breadth and depth of their survivorship. So we did interviews. It was not me, it was a trained research assistant, because they love talking to patients. They're much better at talking to patients than surgeons. So they did these interviews looking at what impact thyroid cancers had on their life. We did tick off a whole things of things we wanted them to talk about, but we really tried to let patients voice their concerns in their own words. We analysed this in a very robust thematic analysis, which I won't go into the details of, but we came to 3 themes, which is that the impact of thyroid cancer diagnosis is very significant for these patients, and the treatment is quite life-changing, even if it just changes their locus of control and their view on life. Thyroid cancer doesn't happen in isolation, and that we need to treat the patient in their context. A lot of patients had significant social issues that impacted their ability to have treatment and make decisions. And patients really valued their clinicians, not just for their clinical expertise, but also for the supportive care that they felt that they received from them, even though the clinicians didn't perceive themselves as delivering supportive care. So the take-home points, if we put all of this together for me as a clinician, is to remember that in practice, the word cancer evokes a very strong emotional response in a patient, and that fear of cancer recurrence is common, and that it influences treatment decisions and also quality of life. And so for patients with low-risk thyroid cancer, we might need to give them time to come down from that anxiety associated with the word cancer and to understand the reality of their cancer diagnosis. When they do have treatment, persisting symptoms are very common and they drive quality of life deficits. Our patients reported that when they tried to raise persisting symptoms with their clinicians, that they felt they were dismissed and not heard, and there was nowhere else to go. Patients derive significant reassurance from all of us, their healthcare providers. Information's empowering, and we found significant gaps in information, content and timing, which led to the decision aid materials that I presented last night. Patients really appreciate being involved in decisions and having the opportunity to air their values. Even if you actually end up making a decision with them that isn't what their values they were aired, at least they feel heard. And care navigation would benefit many, and follow-up should include not just physical care, but also psychosocial support. So where to next? Well, we're developing shared decision-making resources. We're looking at how we can integrate supportive care into routine clinical follow-up with both screening for significant distress and kind of clinician-led supportive care for those with less severe needs. Finally, I thank there's a lot of collaborators in this. We've had a bit of funding along the way as well. And I invite you all to join us in Sydney next year again. Thank you.
Thank you, Shane. That was exceptional talk. And like many of us could relate with that talk. Like sitting in OPD, we feel that the patient who is very low risk seems to be more anxious than a person who is having high risk. And like you concluded that clinician could also kind of support in that journey. And I often wonder, sometimes I feel like when patient has a goal, like you give them 5 years to live, if I can just think compare it with breast cancer, maybe they are this thing coping it in better sense. But when like in first consultation itself, we tell them that this is a very kind of low risk cancer and you would be living quite long with that. But I'm thinking that I'm giving kind of positive thought to the patient, but patient is thinking like that they have to come back again and again to doctor in order to know whether the cancer has recurred or not. So that is kind of very pertinent, and maybe we should word our uh, consultation and counseling to patient very carefully, what to use and what not to use. And like ATA has also worked in that direction, how to decrease or increase the interval between follow-up, particularly in cases of low-risk patient. So any thought on this aspect, that how intense would be your follow-up? Or would that also impact that?
Yeah, I think there's a few barriers in this integration of, supportive care is one is, our guidelines keep changing. We had a great presentation looking at how the guidelines from 2015 have changed to 2025, and it's hard for patients because we give them an estimated risk prior to surgery, but we all know that that may change again after surgery, and then we re-risk stratify them and re-risk stratify them, and that can be a little bit difficult for patients to kind of cope with that level of change. I think in compared to the other cancers that many of us treat, which is breast cancer, which has a lot of peer support, certainly where I work, thyroid cancer has no supportive care. And even worse, if you do go looking for it online, you get directed to the head and neck cancer sites and they come in asking if they're going to have a tracheostomy or a nasogastric tube when they've got a 1 centimetre papillary thyroid cancer. So it's actually almost harmful. So there needs to be kind of independent support for thyroid cancer. And I actually think a lot of it's pretty simple. I think a recognition that our role is actually not just as, follow-up is not just about blood tests and ultrasounds, but even just a quick 30 seconds check of how are you going? How is this impacting your life? Is this causing you any problems, is very helpful. They've been trialling a fear of cancer recurrence screener in breast cancer patients in Australia. The oncologist wanted me to run that for 7 minutes, which I said was completely impractical in surgical practice because my average consultation for a follow-up patient lasted less than 7 minutes. But I was able to build it down to, do you get worried about your cancer coming back? Yes. Is it just before you have this appointment or is it all year? No, it's just before I have this appointment. That's normal. You're normal. That's fine. Whereas if it's not, you occasionally unpack someone who actually needs to go and see a psychologist. I'm not that person, but I can refer them. So I think we just need a few quite simple tools to help us to screen for distress in the clinic. It's probably just 2 more questions for the surgeon. I don't think it's hard.
I think that is very important advice from Christine to the young surgeons and residents. Like we need to spend some time with the patient, just not look at the patient report and say everything is all right. So patients have traveled so far to make that appointment, and they literally have concern. That's why they are coming to us. So I think that is your main.
Okay, thank you so much. We move ahead with the panel discussion. So for next 15 minutes, we have Professor MJ Paul as the moderator for this panel on need for India's specific guidelines for thyroid cancer. There are numerous guidelines across the globe. Are they all applicable to us? Do we need our own guidelines? Dr. Paul.
Okay, so not exactly quite sure how to prepare for this, but so when in doubt, I just did a quick AI. I mean, I've been recently trying to resist the effect of AI in my life, but here I thought, okay, let's see what it does. So I just threw up this question and produced this PPT from AI. So what are the controversial ATA thyroid guidelines in LM that may impact the practice in LMICs? But I started first with two. I can remember when I first read the guidelines, what I was troubled by. Traditionally, we always thought that solitary nodule has a higher risk than multinodular goiter, but the ATA doesn't say so. So the nodule is, whether it's multiple solid, doesn't make a difference. So, but if you actually look at the data, there is, a difference in the percentage risk. And we have few papers institutional based from the country, which all show that a solitary nodule has a higher risk. So then, is it a risk or not? So that's one question. The second question is, it says if you have a hot nodule, you don't have to worry, it's benign. You don't even need an FNA. Just treat it benign straight away, which is again not true. We've had several hot nodules that have come back malignant. The percentage is less than 5%, but if it's 4%, it still worries me. So can I just leave it alone? It should be read as, you have to assess that nodule independently, physical ultrasound characteristics, and decide if it needs an FNA and then treat it like any other nodule. It's not just that you can write it off that every hot nodule is benign and don't have to look at it further. So these were two that concerned me initially. And then a few points about nodules and differentiated cancer, about prophylactic sentinel neck dissection, whether lobectomy is enough, the whole question of targeted surveillance, and about TSH suppression as well, the use, whether how fine-tuned it has to be, what duration, all these things are different in different countries. Of course, this is a non-cancer topic, but even the management of Graves' disease, the use of TRABs, is MMI long-term an option? These are things that happen in our country. We don't, not many people use TRAB. MMI is often used for many years before they come to definitive therapy. So these are some points that I just raised. So that's sort of summary of it. So I would first like to raise the question, each of the panelists, has there been any concern raised in your mind when your practice that you've seen, when you tried to follow international guidelines, any specific each of you can share? And then we'll take it from there as to why we need to do our own guidelines. Chitresh, could you start?
So most often, if we try to convey the patient or try to tell that, look, you are having cancer on only in the one lobe, and there are guidelines which can say that it's a low risk, size is small, it has not spread it to the lymph nodes. So the hemithyroidectomy will be suffice for you. But the thing is, I mean, we are literate and we have discussed, we know all the things. If you think on the patient's perspective, they are always in worry that half of the gland is being removed. There is a chance in the other gland and other half also. And if they ask the same question to us, so what about the other gland? So we cannot say that, okay, it won't be there in the other half. So we have to say the truth that, okay, there is a risk. So then they think, if I'm undergoing the surgery, and if it recur in the other side, I have to subject it to the surgery again. So most of the time they are apprehensive. And if ideally we ask them what you want, they want single surgery, do the total thyroidectomy, and if we want to do the prophylactic lymph node dissection central compartment, at least do in a one sitting. I don't want to be at risk at all. So this is the most of the time they uh, choose for the total thyroidectomy and plus minus central compartment lymph node dissection.
Okay, yes, thank you. That's an important, it's exactly same problem we face, especially when patients are at a distance from centers, that regular follow-up becomes an issue. The concern about recurrence on the other side, when they have half knowledge and they are bombarded by all sorts of information everywhere, it is a worry that hangs in their mind. So I think patient involvement in the decision, that's what we are taking here, that both options are explained. And therefore we can, so those kind of things have to be included in guidelines so that people know that they are not doing anything that is against what is prescribed. Yes. Okay. Thank you. Chandra.
Yes, similar feeling with me as well. Follow-up of our patient, especially the part I practice in, is always suspect. And maintaining too intensive a follow-up creates trouble from them, practical troubles. We do not availability of radio iodine and scans. That is again a problem because it is not equally distributed in all parts of the countries. And ATA guideline, it has somehow a bias towards frequent radio scans and radioiodine therapy as well. So many a times I feel that even patients who do not require radioiodine therapy or a scan, they are probably advised radioiodine therapy if we follow the ATA guidelines, and a very strict regimen of follow-up that probably is difficult to cater to.
Okay. Thank you. So maybe perhaps our guidelines need to offer options in follow-up depending on the situation and the economic profile. I don't know, that's something we have to think of when we do the guidelines. What is the minimum required and what can be done depending on the economic and capacity of the patient. Yes. Vivek?
I think I share same concerns as Chitresh is having. My patients again, they would opt for a short treatment, one-time treatment, minimal risk of follow-up recurrences, and making them understand this concept of minimalistic approach and better quality than insisting on a longevity is difficult, to put in their head. And then again, in practice, there is another concern that patient takes multiple opinions and everybody will have a different opinion. Standard guidelines are practically not followed by all. So sometimes you have to take into account patient's wish, and they may go totally against the guidelines. So all these are, common
Yeah, those are
concerns.
practical issues.
Practical issues.
I mean, we
yeah.
have the guidelines that's true. What works in your clinic may be different.
Yes.
That's a choice we make with the patient. But
Yes.
don't think whether that can be sort of incorporated in guidelines. But you may say, yes, I know that's there, but it doesn't work here.
Yes. Exactly.
Yes, Dr. Pul,
I think I would share the same concerns, but what I see is we experts also not on one plane. We have we discuss something in the conferences. The moment we go to OPDs, we practice something else. The Indian patients, I think most of the patients come and say कि डॉक्टर साहब आपको जो करना है आप करिए. You take a decision. In that scenario, I think putting the onus back on the patient कि हम patient के हिसाब से खेल रहे, that is an oversimplification. I think if we can counsel the patients well and gain their confidence, I don't see a reason that they will not abide by our advice. So, and the problem with our country, I think we'll have to have a set of guidelines, one for government hospitals, one for corporate hospitals. At one place we play by money, the at other place we play by a OT list, that we don't want less than 8 or 9
want-
patients in the.
You want a guideline for people who would not follow the guidelines.
Sir, if we look at the Indian Thyroid Society, I think Dr. Hemgirish was also there. It was published in May 2024. It looks more like a review article. And I think 12 authors are playing for the entire thyroid surgeons within the country. So we don't expect once we make a guidelines with such kind of an background, we'll have enough people to follow. And I think all the educational institutes within the country also, our residents go out with different ideas, sir. Matlab, having done my training here and then working at KGMU, probably those may be practically correct, but I think we need to come to a path where theory, all these practical problems, and also some amount of ethical thing comes into it, sir. यहाँ पे तो रहता है कि one unit probably in institute says कि आपको नहीं operate करना है, the other unit will tell नहीं आपको करना है. So if that happens within an institute, going to different hospitals, I think might take, and that summarizes. I don't know.
Come back to the question again. Were there any specific recommendations in international guidelines that you found were difficult to apply, and therefore you need to have a separate guideline? When you practice, did you have that?
So definitely, I think it happens right from the diagnostics part to the all Indian guidelines. Indian Thyroid Society says just get a TSH done and then follow T3, T4 if it is abnormal, and then free to. But practically, what do we do? कि हम लोग T3, T4, TSH, or probably everyone follows it. Otherwise, patient will have to come for multiple visits. So right from the issue of T3, 4 TSH to the performing the ultrasonography and then the FNA. I think half our FNAs are performed before the ultrasound. So right from the diagnostics to the surgical decision to the follow-up, I think what is given in the Western guidelines and even the available Indian guidelines, majority of us don't follow it. So just not needing needing a guideline is definitely necessary, but we should probably come up with something which is then followed by most.
Okay, I think there is one issue here that you have a standard which you have set, and you may not be able to reach it for practical, logistic, and financial considerations. That is different. I don't think those can be made into guidelines. Those are practical issues that we face day to day, and we have to make those decisions on the table with our patient. But if from a formal guideline, would you say how does Indian practice differ from international, that we will say this the standard can change?
So if we take the ATA guidelines, I think the 2025, there is too much emphasis on molecular diagnostics. I don't think we can follow that or come close to it even in the next 15 to 20 years. So. That's what I anticipate.
Yeah, so the first point says that, and I think sometimes what you said is right, that you see a lot of work going on that's being pushed, and some people just jump into it without realizing that it's not yet fully established, and you didn't waste your money yet before you get good data. So those things can be included in the guideline. What is the actual practical value, and where is it really suited, and still how much of it is still under consideration before it becomes a recommendation?
I think probably one suggestion would be, when we come up with a guideline, a practical one in easy language, what's the minimum that needs to be done and what can be done, but what are the potential advantages and disadvantages even with that? So.
Thank you. Yes. Dr. Gyan?
Yeah, I agree with the panelists. And apart from that, I want to say that India is a country of diversity. There are diversity of food and diversity of religion and all these things. And even the regions, like we are living in a iron deficient area. So we don't know the behavior of the tumor in our area rather than the Western area. And similarly, the food and other things. So we are totally different than what the guidelines made from the entire world. So we should have our own guidelines for our own people, that whatever we follow, that should be helpful and that will be the fitting to our patients. And second thing is like rest other things like Kulranjan is saying. So same for the follow-up and following by the patients, because the patients, we are not compelled, or our patients are not compelled with the insurance company. So they have their own choice, whether they go for the indigenous treatment, they go with the higher center, they go with the corporate sectors. So they have lots of choice. So once they have choice, then there is a diversion. So if you don't have any choice, if you have a fixed the guidelines, means if the government's or healthcare system is like that, that you have to follow the instruction of the primary healthcare physician to the specialist to the higher centers. So if they are following that path, then they have to follow the instructions given by the. But in our country, it is they are free, and they usually that's why and all the Indians, that's why they are not following, and usually the basically Indians are means careless for their health. So majority are not caring. So once you even the you instruct, they are free and they are going to the other centers and they are following whatever they are. Even like a surgical procedure you are saying, if you are not operating, so they are if you, they go to the private center and they operate. So how they follow the guidelines? So we have to think about the problems, our start from the healthcare system and entire the patient scenario, diet scenario, and other these things. So looking all these things, we need definitely needs our own guidelines.
Yeah, thank you. So I think the guidelines need to reflect to some extent the practical concerns. Yeah, we're running out of time. So what I'll do is, I think you raised one important point that even within India, we have different sectors with different issues. And that also needs to be recognized in guidelines, especially with iodine sufficiency and excess. So can I ask Dr. Anjali yes, to make a comment? Dr. Anjali being the president of the association is now coordinating a guideline thing.
Yeah. So I think some of the consent, to majority of our this thing members have already received that invitation, and we would be floating first rounds of Delphi survey, hopefully by next Monday. And we are in the process of preparation of that. And keeping in view of diversity, what the IAS has done is that we have included university, not only university surgeon, those who are practicing in tertiary care center, also those who are practicing in medical college, specialist surgeon, those who run the unit. And apart from that, we have included corporate people who are practicing in corporate, but these all are members of IAS. And like first we thought we would be formulating the question and then floating it. That's why it got delayed. But later on we thought like we will ask the experts ki what that would be first would be open-ended kind of thing. Some question would be floated, then we would ask them ki what other question and concern they have, so that that would be included in the second round. So I think we would be making that start very soon, and with cooperation of everyone, hopefully at least we would be able to make first draft. Final draft would be made during that IS conference, annual IS conference in Mangalore. We would be having this thing, a survey from all of the audience, whosoever participants are there.
Ma'am, one sir.
Yes.
So if we include too much of logistic issues in the guidelines, won't it be a deviation from a lot of scientific or evidence-based guidelines?
So
Because
we
our
put that
concern
in
are
standard.
our concern are mostly logistic. Having our own guidelines means first we have to have a robust data. Otherwise, we are just changing based on the logistics. So that anyway, everybody is changing for their own, needs. So we actually don't. We have a set of guidelines. They are to guide, but what we are practicing is anyway, based on the logistic issues. So formulating that thing again, I mean, big thing
It's
we are
also an encouragement to for everybody to overcome their logistic challenges to meet the minimum standard of the guidelines.
That's what we would be liking, like as per WHO criteria, that would be minimum, optimal, and wherever this thing that is possible, maximal, but whatever could be done. So we would stick to that kind of benchmark.
But minimal, I mean, how do we?
So let's this thing start with survey, because you people would be coming out with questions. What questions to ask, and that
Yeah, all that will be incorporated in the Delphi technique. Thank you.
Okay, thank you very much to all the panelists.
Thank you, everyone. We will now move on to our next session. That is a presentation on subtyping and newer classification in Cons adenoma. For this, I would like to invite to the dais our chairpersons, Dr. Gyan Chand and Dr. Him Girish Ram. I would also like to invite our presenter, Dr. Shibendra Verma. Thank you.
Good afternoon to the chairpersons, and thank you and congratulations to the Department of Endocrine Surgery for organizing this wonderful event for 3 days. And I have been given the task of speaking on subtyping of Cons adenoma. So probably it's more of a pathologist domain, but I will add a little tinge of endocrinologist perspective into subtyping. So my agenda is divided into 5 parts. Zonation in normal adrenal glands. What about evolution of adrenal secreting cells during normal lifespan? And presentation of aldosterone producing adenoma based on specific markers. Then I'll follow up with the latest Histology guidelines based on histological, and I'll add the biochemical subtypes that may come in future probably, and followed by summary. So just to brush up, this is our normal adrenal gland divided into 3 zones. The outermost is zona glomerulosa, then followed by zona fasciculata and zona reticularis. We are concerned more with the zona glomerulosa, which secretes aldosterone, and it constitutes around 15% of the gland, does not express 17-alpha hydroxylase enzyme, so definitely does not produce any cortisol. Importantly, there is restricted expression of aldosterone synthase enzyme, and this is important to understand the Histology classification, that if we can somehow establish the fact that aldosterone synthase staining is there, then we are sure that this is aldosterone producing nodule, micronodular adenoma. It is also important to understand why there is only aldosterone synthase restricted to zona glomerulosa, that the promoter for aldosterone synthase is controlled by angiotensin II and not ACTH. And that's why in type 1 glucocorticoid remediable aldosteronism, which is kind of familial hyperaldosteronism, unequal crossing over of the promoters leads to ACTH being able to stimulate the aldosterone synthase enzyme. With this background, let's move on to the conventional and variegated zonation of normal adrenal cortex. And this is based on the pioneer work of Nishimoto et al., which have discovered the polyclonal antibodies for aldosterone synthase. Later on, monoclonal antibodies were also discovered, and now they are available commercially. Till now, in SGBGI, we are not having aldosterone synthase. Let's understand, though it's a busy slide, this slide particularly speaks about the normal adrenal glands, particularly in the younger individuals, where you can see on the left the hematoxylin-eosine stain, and it's a normal adrenal gland. And on the right side of the figure, you can see the staining with aldosterone synthase and 11-beta hydroxylase. The bluish color just tells you about the normal presence of aldosterone synthase enzyme. So normal adrenal gland, normal histopathology, and a normal usual presence of aldosterone synthase. But what happens into the older individuals, even in normal patients who do not have aldosteronism, there may be some variegation in the hematoxylin-eosine stain, and there may be evolution of aldosterone-producing cell clusters, which are detected by aldosterone synthase positive staining. This can happen in normal individuals, and we know this work actually leads to the development of later somatic mutation, which we will discuss later on. Further, this group in 2017 also published a fact in, again, patients who do not have primary aldosteronism in the autopsy of the adrenal glands done for other reasons, that there are mutations present even in those aldosterone-producing cell cluster, which were not clinically related with aldosterone-producing adenomas. And with the next generation sequencing of all those genes which are usually associated with either somatic mutation associated with aldosterone-producing adenoma, or even just some rare cases of germline mutations, they just checked it whether these APCCs or cell clusters have those mutations. And to their surprise, they actually found there is a high prevalence of those mutations which are usually associated with aldosterone-producing adenomas. Common one they saw is the calcium channel mutations. It is slight deviation from usual aldosterone-producing adenoma, which have more of KC and J5 mutations. And with this background, I'll move on to the Histaldo classification, which has recently devised the classification of Cons adenoma. So now we have a usual histopathological staining H&E stain, which were previously used for reporting of aldosterone-producing adenoma. On top of that, we can now use aldosterone synthase staining to subtyping these aldosterone-producing adenomas. So what this consensus procedure of Histaldo was, so among the 97 patients with unilateral primary aldosteronism, 37 adrenals representing the histopathological spectrum of unilateral primary aldosteronism. Of course, the patients who were diagnosed clinically with primary hyperaldosteronism, they were subjected for initial building of consensus based on usual histopathology and aldosterone synthase staining. So initially, the group 1 pathologists just did based on H&E staining, and then followed by assessment with addition of aldosterone synthase staining as well. Then there were collaborative decision making based on open questionnaire, dichotomous questionnaire, and face-to-face meeting. Finally, they actually devised how to classify these Cons adenomas into various subtypes, followed by consensus validation by group 2 of pathologists, which validated the whole classification. As far as the classification is considered, now we are coming to the actual subtyping of the Cons adenoma. 6 subtypes now we can see with this classification. The rarest one is, of course, aldosterone-producing adrenocortical cancer, which is quite rare, and the malignant features like necrosis, capsular vascular invasion, high mitotic rate, which are usual features of ACC, are also found. Along with that, you can see the aldosterone synthase staining is also present. Of course, this is not the talk of discussion. We now move on to the next one is aldosterone-producing adenoma. The classical finding is they are usually more than 10 millimeters in diameter. So anyone to classify as aldosterone-producing adenoma, it has to be more than or equal to 1 centimeter in maximum diameter. And it should be aldosterone synthase positive, as well as on H&E stain, it can give us a clear cell type, which are more of a lipid-laden cells, or compact eosinophilic cells are present. If this nodule is less than 10 mm, of course, other features are present like aldosterone synthase staining. It is distinct from the normal adrenal tissue. Then we call it aldosterone producing nodule. So this is just a difference of size differentiates from adenoma to a nodule. Now there is another entity called aldosterone producing micronodule or APCC, which we have discussed few slides back, where again there is aldosterone synthase staining is present. And it is composed of a usual adrenal tissue that is not, you cannot differentiate. There is no differentiation against the normal adrenal tissue present adjacent. Further, there can be a lesion where you don't find a solitary lesion. You can find either multiple aldosterone producing nodules or multiple aldosterone producing micronodules, which are formerly known as macronodular hyperplasia. And again, the features are similar. Only thing, either these micronodules are multiple or these nodules are multiple. Very rarely, there can be a diffuse hyperplasia where broad and uninterrupted strip of zona glomerulosa cells, and more than half of these cells display aldosterone synthase positivity. So this is usual presentation of these different types of Histaldo classification, aldosterone producing adenoma. On top of A and B, you can see aldosterone adenoma. Here, HND stain and aldosterone synthase stainings are used. So you can see in an HND stain, clear cells are usually visible along with diffuse staining of aldosterone synthase. There can be slight variations that this staining can be little bit scattered. It's not diffuse, but again, based on size features, HND stain and 11B2 staining, it is again classified as adenoma. If you want to classify from non-functioning adenoma, you can see the all other features may be same on HND stain, but the staining pattern, aldosterone synthase stains are negative in non-functioning adenomas. So any nodule which do not stain for aldosterone synthase, it cannot be classified as aldosterone producing adenomas. And this is about multiple micronodules or macronodules and very rare cases of diffuse hyperplasia. So this is how histologically it is being classified. But what about cortisol? There have been so many papers that these aldosterone producing lesions, either in the same nodule or in adjacent nodules, they produce cortisol. And this subclinical hypercortisolism actually leads to lower clinical success rates. Along with that, the dysglycemia and other metabolic parameters can also be deranged. So what is the importance of this cortisol co-secretion? There can be increased dysglycemia along with metabolic derangements. And many a times we do see many patients presenting with uncontrolled diabetes, and we may have missed out those cortisol co-secretion. There is high incidence of psychiatric issues, as well as once we take out these lesions, there could be a transient suppression of HPA axis, and these patients may need transiently glucocorticoid replacement doses. Sometimes even the interpretation of adrenal venous sampling can be problematic because the nodule which is producing high cortisol may have abnormal selectivity index, and then we may see that this is actually attributed to the cortisol secretion from that particular nodule. So with this whole scenario of histological classification based on HND stain, aldosterone synthase, and cortisol co-secretion, I would like to summarize this whole classification of Cons adenoma. So we know that with aging, there may be some somatic mutations hitting up, which may lead to the development of micronodules or cell clusters of aldosterone synthase secreting cells. With progressive aging, again, there may be some addition of mutation where these develop into progressive primary aldosteronism, where renin gets suppressed and aldosterone keeps increasing. Finally, there is neoplastic conversion, and we find APA nodule or adenoma. Other occurrences could be these adenomas can coexist with non-functioning adenomas, which you can document with aldosterone synthase staining. And sometimes if you can see the cortisol co-secretion can be a single nodule producing both cortisol and aldosterone. It could be a separate lesion, this cortisol secreting adenoma, or sometimes there can be micronodules at one site and cortisol secreting adenomas at other places. So this is how this all can be present in a particular patients of Cons adenoma. And I've summarized everything. And thank you all for the patient hearing, and I'll be happy to take any comments or suggestions.
Yeah, that was a very crisp presentation, so thank you. Any questions from the floor? I have one myself. Is there a correlation between the clinical features of a patient and the various histological, pathological subtypes that you described?
Actually, since my experience per se, for this type of classification, having micronodules, nodule per se, or adenoma, it's not there. But all these patients, those who have been classified based on the various histological classification, they were severe Cons adenoma patients. And if, in fact, if you see the whole scenario or presentation of this Cons adenoma, Even some of these severely presenting cons patients also, the aldosterone levels may not be that high. Even we do the saline suppression testing, some of these aggressive cons patients also have a good suppression on the saline. So definitely as of now, what I have gone through the literature, various subtypes like micronodules or you say nodule adenomas may not clinically reflect every time. They may be like, or sometimes it's some multiple micronodules producing, there are multiple sources of aldosterone secretion also.
Yeah, thank you.
Thank you, Dr. Verma, for nice presentation. So just same like micronodular, macronodular, and adrenal adenoma. So these three different clinical scenario what we faced. So what about this incidence of unilateral versus bilateral? So do you have any correlation with these?
If you say hyperaldosteronism per se, what I have talked is just the cons adenoma because the classification is based on unilateralization of the aldosterone secretion on ABS and resection and followed by the classification they have made. Clinically, those patients who have a bilateral adrenal secretion, we do see a lesser degree of hypokalemia and lesser hypertension in bilateral hyperplasia compared to the cons adenoma.
Any other questions? If there is no questions, thank you very much. Thank you for.
Thank you, sir. Thank you.
Thank you, sir, for this insightful lecture on cons adenoma. We are running late, so we'll cut short our subsequent sessions. Incidentalomas are emerging challenge discovered unexpectedly due to expanding use of imaging. And it is raising important questions regarding the clinical significance and management strategies for the same. So our next session will shed light on incidentalomas in endocrine surgery. For the same, I would like to invite to the dais our distinguished chairpersons for this session, Dr. S.K. Mishra, Dr. Munir Wani, Dr. Pradeep PV, and Dr. Anurag. We would like to cut short the sessions due to time constraints. I would request all the presenters to keep the presentation brief and crisp.
Okay, let's start. Yeah.
Good afternoon, everyone. I'll take the thyroid incidentaloma and I will discuss definition, significance, evaluation, and prognosis. Coming to the definition. So, it's a simple definition is clinically inapparent thyroid nodules discovered serendipitously on imaging for non-thyroid indication are termed as thyroid incidentaloma. Or in other words, we can say thyroid incidentaloma or incidentally detected thyroid nodule is defined as nodule not previously detected or suspected clinically, but identified by an imaging study. The meaning of this two simple line that we will see in clinical scenario. So first patient, a patient having neck pain and underwent neck ultrasonography, and in the ultrasonography we found a thyroid nodule. So most of us will agree this is not a thyroid incidentaloma. Another case scenario, a patient of compressive myelopathy, MRI was done and they found collapsed T8, and on FNSC they found thyroid follicles and reported as FTC. Then she underwent USG thyroid and they found a small nodule in the thyroid. And then again, this is not a thyroid incidentaloma. Most of us will agree. A patient came for gallbladder stone disease and physician clinically suspected enlarged thyroid gland. Then he evaluated and it was found 3 centimeter nodule in lower pole of the thyroid lobe, left lobe. So there may be a split in this scenario. Some of us may consider as a clinical incidentaloма, but ideally it is suspected clinically. So again, this is not a clinical thyroid incidentaloma. So coming to the incidence, incidence is rising, and this due to continued improvement in the quality of imaging. And every radiologist going to report everything, whatever they find in the imaging. So they are afraid of litigation. So incidence is almost improving. Prevalence: thyroid nodule disease is a common adult illness with published prevalence ranging from 26 to 77%, and that depends upon age, sex, and imaging modalities. So clinical significance, as I told, this is depends that depends the rate of identification, depends the modality what we are using. So in case of the autopsy, we found up to 50% of thyroid incidentaloma. Among them, 30%, 36% may be malignant, and mostly the PTC. On ultrasonography, we found up to 20 to 67%, and among those who underwent surgical operations, and we found 12% of rate of malignancy, those detected by ultrasonography. And in CT MRI, it is up to 16 to 18% detection rate of thyroid incidentaloma. However, malignancy rate is 0 to 11%. In PET, FDG PET scans, sorry, PTG, scans, rate of identification is so low, 1 to 2%, but however, it is rate of malignancy is so high, like 33 to 35%. So coming to the multiple studies, the Davis et al. Who reported as the rate of incidence that tripled between the 1975 to 2009, and there is a disproportionate increase in small papillary cancers, but mortality remains stable. This is a large studies report done by the Harrick et al., and they found untreated papillary microcarcinoma found no cancer death over 10-year period, and no new nodal metastasis was only 3%. And even less than 2 centimeter of PTC of 10-year survival, 10 year, they have greater than 10 years survival. 99.9% have greater than 10 years survival, and failure to diagnose these cancers is unlikely to affect morbidity and mortality. And there is a combined statement by Carrie M. Kitahara and Julie Esosa that the problem of overdiagnosis and overtreatment of disease that is typically indolent, where treatment-related morbidity might not be justified by a survival benefit, now seems to be acknowledged. So with this background, we can say the diagnosis of incidentaloma poses the minimum threat. So with this background knowledge of clinical significance of thyroid incidentaloma, American College of Radiology in 2015 came up with the Incidental Thyroid Finding Committee, and subsequently they came up with a thyroid scoring and further evaluation. So to evaluate this thyroid incidentaloma, our aim is to diagnose, to avoid overdiagnosis and unnecessary treatment, at the same time not to miss the malignancy. But exceptions are those increased risk of already patients having increased risk of thyroid carcinoma, symptomatic from thyroid disease, or pediatric patients. And during evaluation, we will consider the type of imaging, age, and size. This flow chart is taken from the Incidental Thyroid Finding Committee by the American College of Radiology in 2015. There is a 3 type of box: yellow, red, and green. Yellow box dictates the management, and this based on the data, while red one is just to stop further evaluation, and green, if it is found greener, then we have to evaluate further. So this is detected by the CT and MRI, and this is PET detected incidentaloma and findings. In case of the PET detected and metabolically active, we have to evaluate by thyroid ultrasonography and FNAC. These are some studies that also dictates that association of FDG PET and FDG PET avidity and the rate of malignancy. The last month of ultrasonography detected thyroid nodule, and we again will follow the same sequence of further follow-up, and will do whatever the thyroid scoring came up. The prognosis is much better than, and there is a one study, the systematic review, where they compared the incidentally detected and non-incidentally detected papillary thyroid cancer, and they found that incidentally detected thyroid cancer had better progression-free and overall survival. Thank you. So take-home message is thyroid nodule is a common hidden issue in general population. If detected, further evaluation, their management needs a holistic approach. Thank you.
Thank you for that presentation. Thyroid nodule incidental finding is now very common, and you can see a lot of recommendations also coming up. So it's going to keep evolving like that. Anyway, we'll go to the next presentation. If there are any questions, we can take from the floor. Okay, to the next presentation. Parathyroid incident, Dr. Spandana.
Good afternoon, everyone. I'll try to keep my presentation as brief as possible. Dr. Madhu has already described what an incidentaloma is. It is defined as a mass. It is defined as a mass lesion discovered serendipitously, usually during imaging done for some other indication. Endocrine glands are notorious for these findings, and parathyroids are no exception. However, they are rare. The incidental discovery of parathyroid tumors was first reported by Ali et al. In 1967, while he was exploring the neck. With the availability of high-end radiological imaging, there has been an increased detection in these lesions, which has created both opportunities and dilemmas for the endocrine surgeon. For ease of understanding the management of these lesions, I will be dealing with parathyroid incidentalomas by categorizing them based on the method of detection. So we have radiologist detected, surgeon detected, and pathologist detected parathyroid incidentalomas. The prevalence depends very much on how the lesion was detected. In neck ultrasound series, it is around 1%. In thyroidectomy series, rates range from 0.2 to 4.5%. And in autopsy series, the incidental parathyroid lesions have been reported in about 2 to 7%. Several hypotheses of etiology also exist. Some suggest prior radiation exposure, while others have studied genetic factors such as polymorphisms in the calcium-sensing receptor gene. But the most widely accepted idea is that many parathyroid incidentalomas may represent an early stage of parathyroid disease, either a preclinical adenoma or a hyperplastic gland that has not yet produced biochemical abnormalities. Starting with incidentalomas detected by radiological imaging, on ultrasound, parathyroid lesions typically appear as well-defined oval hypoechoic nodules, separate from the thyroid capsule, located posterior or inferior to the thyroid, with a characteristic finding, which is the feeding artery sign, seen in about half of the cases where the polar vessel enters the lesion. But there are several pitfalls. The sensitivity is about 65 to 85%, and the positive predictive value is low in the presence of background thyroid disease such as multinodular goiter or thyroiditis. This means thyroid nodules and parathyroid lesion can easily mimic each other, making misdiagnosis a real risk. The first key clinical question to be asked is not only whether a lesion is parathyroid in origin, but also whether it is functional. There exists sparse literature on this, but few studies have shown that functional tumors make up about 1/3 of the cases. Once functionality is confirmed, we need to assess the need for surgery, and localization studies are done if surgery is planned. For biochemical evaluation, we rely on the same test that we use for primary hyperparathyroidism, with corrected calcium and serum PTH being the most important screening tests. Repeated serum calcium tests may be needed as many parathyroid incidentalomas are normocalcemic at detection. If imaging is inconclusive, FNAC with washout PTH can be helpful. In a recent study, the diagnostic performance of FNA for parathyroid incidentaloma showed a sensitivity of 31%, specificity of 100%, and an accuracy of 78.5%. And they recommended taking at least more than 2 passes to reduce false positive rates. On testing washout PTH along with FNAC, the sensitivity in their study increased to 97.4%. But here's the caveat. There is no universally agreed cutoff value. Some studies suggest washout PTH more than 100 picogram per milliliter or 2 to 3 times the serum level. This lack of standardization is a major limitation in interpreting FNAC result. So what do we do with image-detected incidentalomas? If the incidentaloma is functional or FNA with washout PTH is strongly positive, then it should be managed according to the guidelines for hyperparathyroidism, meaning surgical resection is done if patient meets the criteria. If the lesion is non-functional and the washout PTH is low, then appropriate approach is observation with periodic follow-up, because many of these lesions will remain silent. Moving on to our next category, that is incidentaloma identified by the surgeon during neck surgeries. Across many studies, the prevalence is about 2%. The real challenge now is how do we define an abnormal gland? Some suggest a size of more than 5 to 6 mm. Others propose a weight of more than 50 to 70 milligram. Some also suggest noting the characteristic reddish brown color compared to normal yellow tan glands. But none of these criteria are obsolete. Normal glands can sometimes be heavier and early adenomas can be small. For the surgeons, the choice is difficult when they encounter a macroscopically abnormal parathyroid gland during thyroid surgery on whether or not to remove it. If this were to be a hyperfunctioning adenoma, then the risk is probably justified as the patient's hyperparathyroidism is cured. However, if it proves to be a normal gland, then the patient may have post-operative morbidity without any clinical benefit. On the contrary, if abnormal gland is left in situ, then there is risk of needing to perform a redo surgery and its associated morbidity. In indeterminate cases, intraoperative adjuncts can be used. IUPTH validates resection in hyperfunctioning glands, but the cost, logistics, and time make it impractical to use it routinely in incidental settings. Frozen section confirms that the tissue is parathyroid, but cannot confirm its functionality. Some studies advise fat staining to differentiate normal from abnormal gland by demonstrating loss of stromal fat. So while these adjuncts are useful, none of these are perfect solutions. In practice, the principle is while doing thyroid surgery, one should carefully look for all parathyroid glands, and not only one should avoid accidental damage to these glands, but also abnormally enlarged glands should be identified. If the gland is clearly enlarged and safe to remove, that is, the nerve is not at risk, excision is reasonable. If there is doubt, preservation with clinical and biochemical follow-up is safer. Importantly, there is no role of routine contralateral exploration when incidentaloma is encountered. Finally, moving on to our last category, that is parathyroid lesion found in pathological specimen, post-thyroidectomy. All should undergo both biochemical and clinical evaluation. If found hypocalcemic, then the patient is treated accordingly and put on routine follow-up as we do with PHPT. If the patient is normocalcemic and asymptomatic, there is no indication for re-exploration. Instead, these patients should be followed up periodically with serum calcium and PTH levels. This brings me to the knowledge gaps in parathyroid incidentalomas. There are many unanswered questions like should calcium and PTH be tested routinely before every thyroidectomy to avoid such surprises? What exactly should be the size or weight threshold to mandate excision? Do frozen section and intraoperative PTH truly help in this setting? And finally, for image-detected non-functional incidentalomas, what is the right duration and frequency of follow-up? To conclude, parathyroid incidentalomas highlight the tension between evidence and judgment. While guidelines for PHPT are clear, the management of incidentalomas remains controversial. Until further data emerge, decisions must be individualized, balancing risks of resection versus preservation and guided by biochemical and functional assessment, and above all, patient outcomes. Thank you.
Thank you. Any question from audience?
Is there mic, please?
Maybe I'm loud enough, I think.
Oh, carry on.
What looked up the incidence of
a parathyroid adenoma being there for PTCs recently. So in one study, they quoted up to 8%. So probably it is a good idea that you've, whatever you've mentioned, maybe we should be doing a PTH when we're opening the neck anyways. And we are going to look at the parathyroids. It's just one more additional blood test that we can add to our routine investigation panel for thyroid cases in particular.
Routinely ordering PTH may be a little overdoing the scenario. Maybe if you can, you may check calcium. Maybe it's a via medium to go about it.
The
My
calcium we anyways do for all the patients.
pre-op.
Yes, for all the thyroid patients, we do. That's what I'm saying.
It
At
depends on
SGPJ, we do.
institute to institute. It's not compulsory. My question to you is, Spandana, you said radiologically detected on ultrasound. In the algorithm, you said you will do a FNA and wash out PTH. Now, what intention of doing that? You have a ultrasound suspected parathyroid.
Inconclusive. Only in that cases, some studies have shown that maybe adding FNA with washout PTH might be helpful. But again, these are not validated tools, and there is very less evidence to say that it should be recommended in all cases.
The point is, if you have a lesion suspected to be parathyroid, you can check the calcium, you check the pH, and it is normal, and you have to further investigate it as such, because inadvertently you may put a needle into a parathyroid adenoma, and then you put needles track seeding. We have seen some cases during our MCH course itself, and one case was so difficult to treat. It was recurring again and again.
So that is what we do at our institute, but I was just reviewing the literature and on what are the modalities that have been used and the studies that have been done.
Okay. Just want to give you some idea about this calcium test. Long ago, there was an article, work done by Paolo Micoli from PISA. There they used to do routine calcium estimation to pick up this so-called undiagnosed, not incidentalomas, undiagnosed parathyroid adenomas, but didn't stunt test at the time, and the number of tests done, number of pickups. So that is very kind of vague idea. Rather, I must suggest that you can do vitamin D in many patients because many of the patients are female. They are subclinical hypovitaminosis. So maybe vitamin D may be added. Maybe in your guidelines, something you can think about that. So that this is not going to stand. People do publish many things, but you have to decide what is good for the patient actually. So rare. But certainly you must look all parathyroids during thyroid surgery. That's the only thing I can suggest. So we have fine enlarged parathyroid gland. The only thing that is confusing is a detached thyroid nodule. That may confuse you with this kind of parathyroid undetected adenoma. To find something, you remove it. This is many things you have done it. It will come out a report of parathyroid adenoma. Just ignore it. That's all. And have a next presentation, please.
Good afternoon, everyone. I'll be a little brief because I can see a lot of hungry and impatient faces. So, so I'll be talking on adrenal incidentalomas. So let's start off with the definition. Adrenal incidentalloma is defined as a clinically inapparent adrenal mass more than 1 centimeter in diameter, serendipitously detected during imaging performed for reasons other than for a suspected adrenal disease. And I would emphasize on serendipitous because they say that that means that it is found by chance and it's a good thing. But is that a good thing remains to be seen. And so the term incidentalloma emphasizes the serendipitous nature of these findings. And this, because of the serendipitous nature and it being an incidentalloma, this poses a lot of diagnostic and management challenges for us surgeons or any clinician that comes across this entity. So why do we care? That's because the understanding of the definition is important so that we classify these lesions and we can make clinical decisions in terms of how we want to manage them. And most of the time now we've realized that adrenal incidentallomas, the prevalence has increased because of increase in technological advances in imaging such as CT or MRI, and because we use them so widespread now. And the detection and intervention rates, like I said, was already on the rise. And this term is not a pathological entity, nor is it a disease. And the discovery of an adrenal mass raises the questions that determine the degree of evaluation and the need for therapy. So going on to the epidemiology and prevalence, autopsy studies have shown the prevalence of incidentallomas to the tune of 1 to about 9%, while imaging studies about 1 to 6%. And the prevalence of an incidentalloma increases with age 7% every decade. It's rare in patients less than 30 years, and it's mostly seen with a female predominance. We published a paper from our department on adrenal incidentallomas in a developing country. And we saw that most of the patients were evaluated with an ultrasound because that's easily available. And most of them had abdominal complaints like pain, abdomen, diarrhea, where an ultrasound was done, and an adrenal incidentalloma was found. And most of these patients pathologically were pheochromocytomas at our institute, but that could also have a referral bias. It's possible that some adrenal incidentallomas were not referred to us because they did not need treatment. Data suggests that around most of the incidentallomas are non-functional, and the adenomas range between 30 to about 96%. So coming to the management, the key clinical questions that we have to address is the tumor functional? What tests do we perform to assess functionality? Is the tumor malignant? What imaging can we use to assess malignancy? When do we operate? What is the surgical approach? And most importantly, when not to operate? And how do we follow up these patients? And is there a role for adrenal biopsy? So if the tumor is functional, history and physical examination is very important. It's important to go about it in a stepwise manner. So from the medulla and from the cortex, if medulla, pheochromocytoma, so we would check for headache, sweating, palpitations. From the cortex, we rule out Cushing's, Conn's. We also rule out then if there are any features of metastasis or primary adrenal carcinoma. The biochemical tests that need to be done in all patients is an overnight 1 milligram dexamethasone suppression test for autonomous cortisol secretion. For hypercatecholism, whatever your institute is comfortable with, either plasma or urine fractionated metanephrines. Hyperaldosteronism, we can rule out. When do we screen for these patients? If it's a patient with hypertension on multiple medications, or the patient has hypokalemia, your pretest probability is high that this patient would have hyperaldosteronism. And how do we screen for these patients? We do serum potassium, serum aldosterone, and plasma renin estimation. So if your elevated plasma aldosterone concentration is more than 15 nanogram per ml, and your aldo-PRA ratio is more than 20, that has a high sensitivity and specificity of more than 90%. And we can check for sex hormones. This is usually seen in patients with adrenocortical carcinoma, and we usually do it in patients that present to us with larger adrenal masses. So I won't talk about the normal adrenal findings. I will talk about, however, what to look for in a CT scan, which makes the tumor malignant. So if the shape is irregular, it has heterogeneous enhancement, it has calcifications, the size is more than 4 centimeters. This is relative, taking everything else into account. It has a growth rate of more than 1 centimeter per year. On unenhanced CT scan, it's more than 10 Hounsfield units. And if it is FDG avid, if it retains contrast on contrast enhanced CT. So this is one of the cases. This patient had an adrenal incidentalloma, and the absolute washout was 62 with a relative washout of 44. This was discussed in the endocrine imaging series. And this was suggestive of a benign lesion. This is the patient who had presented to us with bilateral adrenal masses on lower sections of a CT thorax. He was actually being evaluated for breathlessness, and he had some cardiac condition, and he was evaluated to have a bilateral pheochromocytoma. This is an algorithm that we can follow for management of an adrenal incidentuloma with biochemical and radiological characteristics. If on radiology it appears benign, less than 10 Hounsfield units, less than 4 centimeters, we can follow up these patients unless they secrete cortisol without any symptoms of cortisol secretion. These are called mild autonomously functioning adenomas. This is a patient who had an abdominal aneurysm, had undergone an MRI, found with an adrenal incidentuloma. This is another patient who was CA breast, metastatic workup, found to have an adrenal incidentuloma, Hounsfield units less than 10. And this was benign. But is this really an incidentuloma when you're doing a PET scan? No, it's not, because the definition excludes patients with an extraadrenal cancer where you're looking specifically for metastasis. So coming to MAX, these patients usually have an unsuppressed ONDST without any features of Cushing syndrome. They do not progress to develop overt Cushing syndrome. And whether to do a adrenalectomy or not is sort of questionable. When do we operate on these patients? If it's functional, there are imaging characteristics suggestive of malignancy, or lesions more than 4 centimeters, any primary operable malignancy, or isolated adrenal metastasis. And the surgical approach will then depend on the patient's habitus, the likelihood of malignancy, the hormone excess presence, and general health and patient preference. The most important question is when not to operate on these patients. We will observe these patients if it's less than 4 centimeters, a benign lesion, non-functional, and we don't have any suspicion of ACC. We do follow up these patients if they are less than 4 centimeters, benign appearing, smooth borders, homogeneous, non-functioning. This has a strong recommendation with a moderate quality of evidence. The newest ESE guidelines in 2023 said that we can follow up hormonal evaluations not recommended in non-functioning lesions whose hormonal workup was normal at the initial evaluation. This is a strong recommendation with low quality evidence. No follow-up is required in adrenal masses less than 4 centimeters with benign features. However, indeterminate masses need to be followed up with CT or MRI after 6 to 12 months. This has a weak recommendation with very low quality evidence. If there's no growth, no further imaging is required, and we need to have individualized care. We need to operate on patients who are under our follow-up if the lesion enlarges more than 20% or more than 5 millimeter increase in its maximum diameter. These are guidelines from the AAES, which is quite old now, 2009, so I won't get into that. Is there a role for adrenal biopsy? No, it's rarely indicated because it does cause tumor seeding in ACC, and it may be done in patients with suspicion of adrenal metastasis. Very important to rule out pheochromocytoma first. So the take-home points is most incidental adrenal masses are benign, so we don't need to have any surgical intervention for these. And it's important to identify these patients because some of them may require surgery. And this requires an individualized approach. And there have been studies on the future, which will be done in the future. There are already ongoing studies on steroid metabolomics, which has not entered clinical practice yet. So I'd like to conclude my presentation with that.
Nice presentation. I think you covered the algorithm, which is generally practiced in institutions. One thing I want to tell you, what about lymphomas, primary lymphomas of the adrenal?
So these patients,
how you to evaluate those and how will you suspect?
So these patients would have not just isolated lymphoma, they would have hepatosplenomegaly. So you would know that on the CT scan. And if the patient has lymphoma, they would also have these symptoms. So you're looking for something in the abdomen, and that wouldn't be called an incidentuloma as such.
I was looking at the evaluation of these patients. So if your incidentuloma, does the size of the incidentuloma, when you detect, influence your extent of biochemical evaluation in that patient? So how is that?
So at our institute, if it's more than 4 centimeters or it does have any CT characteristics of something that we would consider it malignancy, we would then do an additional DHEAS. Otherwise, that is something that we don't do in our patients.
Okay. So for any size lesion less than 4 centimeter, you'll do all the investigation, including metanephrine, ONDST, and
Investigations. ONDST is done in all of our incidentalomas, as well as we also do urine metanephrine therapy to rule out adrenal and cortical, medullary and cortical functionality.
okay. Thank you.
Thank you, sir.
Question. Audience. Okay. So we'll have the next presentation on pancreatic incidentoloma. Dr. Ashwini.
Good afternoon, everyone. I would like to thank the organizers for this opportunity. As we have already seen so far, incidentalomas are usually lesions in the pancreas which are detected by imaging techniques which are performed for unrelated causes or its implications. Can I have the slides, please? Yeah, sorry. The prevalence estimated is actually quite low, 0.01 to 0.6%. However, when it has been seen in surgically resected specimens operated for some other cause, it has been seen to be as high as up to 23%. And malignant lesions out of them can range up to 50%. That is why pancreatic incidentalomas are actually one of the interesting things to be studied and understood. Out of this, of interest for us as endocrine surgeons is pancreatic neuroendocrine tumors, which would form 9 to 19% of the pancreatic incidentoloma. As the name suggests, incidentoloma per se is clinically non-functioning tumors because they do not produce any signs of hormone excess. So most of them are advanced presentation. Almost 50 to 90% of them could be malignant with metastasis. While smaller lesions are typically indolent with better prognosis, and 10% of these cases might also have syndromic association. So when we work up for the pancreatic incidentoloma, based on the imaging, we see whether the lesion is solid or cystic. In solid, the various differential diagnoses that we can see based on the enhancement patterns would be pancreatic ductal adenocarcinoma, pancreatic neuroendocrine tumors, pancreatitis, pseudopapillary tumors, and other causes. In cystic causes, it could be either pancreatic cystic lesion or non-neoplastic cyst. For cystic lesions, it could be mucinous and non-mucinous. Again, in non-mucinous, something related to us, very rare though, would be cystic neuroendocrine neoplasm of the pancreas. This is just an algorithm of the American Association of Clinical Endocrinology guidelines, where they have the guidelines suggest a workup of asymptomatic patients with pancreatic incidentoloma. In cases of solid lesions with no or delayed enhancement, we suspect pancreatic ductal adenocarcinoma or any focal inflammatory lesions, which is to be followed up with EUS. However, in cases of arterial enhancement, hyperenhancing nodules, there should be a suspicion of neuroendocrine tumors, serous cystadenoma, and accessory spleen. Accessory spleen would follow the washout pattern of spleen, so that is easier to recognize. When we are suspecting neuroendocrine tumors, and if there are any of the worrisome features of size more than 3 centimeter, solid cystic calcifications, Then we have to do further workup with an EUS followed by FNA or biopsy, and also functional imaging and endocrinology workup. In cystic cases, for any size without any worrisome features, actually it can be followed up or an EUS can be done. When we are suspecting cystic neuroendocrine tumors, when it is more than 3 centimeter with enhanced thickened walls and any intramural nodules with dilated main pancreatic duct, then we have to do an EUS. So we have to answer the questions whether it is a functioning lesion and whether it is benign or malignant. For a functioning lesion, actually there is no definitive answer because the patient might have some of the elevated hormonal values. However, in earlier stages, it might not produce any clinical symptoms. And for benign or malignant lesions, an FNAC has to be done and functional imaging should be done to rule out metastasis. So when we are suspecting any pancreatic neuroendocrine tumor, these are the guidelines given by the European Neuroendocrine Society, where anatomical workup with a contrast-enhanced CT scan and MRI should be done to look for resectability and also assess for liver metastasis. Followed by this, EUS with a guided FNAC or biopsy should be done, and also to look for the distance of lesion from the main pancreatic duct. They are recommending functional imaging of somatostatin receptor PET-CT with gallium dotatate, dotanoc or dotatate for whole body staging as well as therapeutic use. Also, chromogranin levels have been recommended in all patients. This is not for diagnostic purpose, but it is for prognostication. And European Society also recommends pancreatic polypeptide and calcitonin levels for these patients. Why are we so bothered about pancreatic incidentaloma? In this young male patient who presents with a pancreatic incidentaloma of hyperenhancing solid lesion in the neck of pancreas of size 2 centimeter, no comorbidities. However, his father is a known case of MEN1 syndrome. Examination is normal, biochemical evaluation is normal. As we all know, in MEN1, there is 80% lifetime prevalence of non-functioning pancreatic neuroendocrine tumors. These tumors are typically multifocal, non-functioning, present in second decade of life, and the life expectancy is reduced almost by 22 years due to liver metastasis. So they have to be diagnosed early. So based on the size, the recommendation less than 2 centimeter, we can observe. More than 3 centimeter, grade 2 or 3 with lymph node metastasis, surgery is recommended. However, for 2 to 3 centimeter tumors, it is a gray zone where individualized approach has to be taken, and any growth of more than half a centimeter per year or any functioning symptoms, then surgery is recommended. Similarly, pancreatic neuroendocrine tumors are also seen in VHL, which have 35 to 70% of penetrance. They are usually good prognosis tumors as compared to other tumors of VHL. Even in this, less than 15 millimeters can be observed, while more than 2 millimeter or 20 millimeters in the head and 30 millimeters in tail, surgery is to be recommended. However, when we talk about surgical procedures, we have to take into consideration the morbidity of pancreatic surgery. Enucleation, which actually has excellent functional preservation, still has a very higher chances of pancreatic fistula, ranging up to 30 to 40%. Lesser chances of endocrine or exocrine sufficiency. As we go towards more morbid procedure, the quality of life of the patient is affected. There is endocrine insufficiency and as well as exocrine insufficiency. These are the few non-surgical management options. These are the Northern American NET guidelines, which are consistent with the other guidelines. Less than 1 centimeter observe, more than 2 centimeter operate. Specifically for MEN1, in cases of multifocal lesions, we remove only the dominant and most accessible lesions. All the lesions cannot be removed. For VHL, up to 3 centimeter or doubling time of less than 500 days can be observed. And enucleation can be done when the tumor is at least 2 to 3 millimeters away from the main pancreatic duct. So this is the Japanese Pancreas Society guidelines. Again, the same, depending on grade of the tumor. Up to 2 centimeter in grade 1, we can wait and watch. After that, surgical resection is recommended. Grade 2 and 3, up to 1 centimeter, we can wait and watch. However, beyond that, surgery is recommended. And in unknown grade, there is a threshold of 15 millimeters. So just a take-home message, when we are thinking of pancreatic incidentalomas, we really need to balance and weigh the options to look for the assessment of the lesion, to look for the malignant potential, metastatic potential, and any syndromic association. But we also need to take into consideration patient performance, morbidity of the procedure, and multidisciplinary team approach. Only then decide about observation versus intervention. Thank you.
Thank you, doctor. That was a good review. Any comments from the audience? I think since we are running short of time, we'll go into the next person.
Thank you, sir.
Thank you.
Good afternoon, everybody. So I'll be presenting the last case of this 3 days academic feast. Can I have my slides, please? So I'll dealing with the breast incidentaloma, which is a very rare occurrence in this incidentaloma series. So I'd like to start with the case, and I'd like to thank Sabha sir for sharing this case with me. So we had one case of 45-year lady who is a postmenopausal lady presented to gastrosurgery department with pain abdomen in right upper quadrant for past 8 months. Was evaluated there with ultrasound and CT. Was found to have features of carcinoma gallbladder, for which she underwent whole body FDG PET CT. The report suggestive of an FD's average lesion of 2.7 subcentimetric lesion, which is noted in the upper outer quadrant of the left breast and referred to us for further management. When she presented to us, she had a 2 into 2 centimeter mobile, well-defined lump in the upper outer quadrant with an axillary lymph node palpable measuring 1 into 1 centimeter and mobile. So we went ahead with mammography, as been projected in this image, suggestive of a BIRADS 5 lesion in the upper outer quadrant of the left breast, measuring 17 and 15 millimeter, with few lymph node with maintained fatty hyla. The ultrasound breast is also corroborated with the similar finding in the mammography. So we made a diagnosis of carcinoma, suspicious of carcinoma breast, and we went ahead with a condylar biopsy, which is suggestive of IDC grade 1, with FNAC of the left axillary lymph node, suggestive of reactive lymph node hyperplasia. And the IAC was suggestive of primary breast lesion of having ERPR positive and HER2 negative with Ki-67 to 10 to 15%. So we had made a diagnosis of carcinoma gallbladder with an left breast incidentaloma, which is of malignant in nature. With this preview of the case, I'd like to review the definition of the breast incidentaloma as been projected here. I'd like to emphasize here is that as with the other incidentalomas, the serendipity term is not really applicable with the breast carcinoma because they are rare diseases, but they're having a high risk of malignancy potential when they're detected with imaging. And the incidence has been on the rising trend because of the advancing and rapid rise of demand in imaging with other imaging in other diseases. So who and how it can be detected? Most common is a radiological detector, which can be detected in CT, PET-CT, MRI, chest X-ray, or in dedicated breast imaging. The next one is can be detected in the OPD or in the clinics by physicians or by palpations, and very rarely by pathologists. So coming to the radiological detected breast incidentalomas, which is most commonly in which most commonly the incidentalomas are found, that can be detected, though very rarely in chest X-rays also. CT scan they are most commonly detected, followed by MRI and FDG PET. So there's an umbrella review showing the prevalence and outcomes of the breast incidentaloma with other incidentalomas, where I'll be only focusing on the breast incidentalomas. So they had reviewed 20 systematic reviews having 240 primary studies. In that studies, they have shown that as is evident in the red box, that there's one meta-systemic review with 9 studies where they have detected breast incidentalomas in FDG PET CT, having a number of patients, 9 96,557, and out of these patients, 292 had breast incidentalomas detected in the FDG PET CT, and having out of 292, 137 patients had malignant diseases. So coming to the incidence of malignancy, which was found in this umbrella review, that the breast incidentalomas had highest malignancy potential of having 42%, followed by ovarian, prostatic, and colonic incidentalomas. They have also mentioned that the CT chest are having a highest prevalence of incidentalomas, including breast incidentalomas, and the FDG PET CT had the lowest chances of detecting incidentalomas overall. Coming to how we can how breast incidentalomas can be detected, though in anecdotal cases it can be detected in CT chest, has been shown this picture that popcorn classification sometimes can be seen in chest X-ray, suggesting fibroadenomas. Coming to the breast incidentalomas, which is detected on CT scan, which is the most common method, the incidence is 0.1 to 7.6% with a malignancy rate of 35%, and if they are detected, then it's further evaluations. So there are some malignancy and benign features of the benign feature of the incidentalomas in CT scan, though they are not very sensitive. As you can see that here, here a patient who are having a breast mass detected in the left breast in the CT scan, on further mammography are having an irregular borders in the breast and further biopsy suggestive of malignant lesion in the breast. These are the two CT images showing benign breast diseases. First one showing fat necrosis having calcification, and the second one showing a macrocalcification in the CT, which are the benign looking lesions. So there are very scarce literatures to how to follow up or manage these patients. Mostly they are given by the radiologist. This is one I adapted from one of the article, that they mentioned that if incidental breast finding on the CT chest, if there is definitely benign findings, then they do not need any further workup. If there is highly suspicious of finding, then it recommends diagnostic breast imaging in form of mammography and ultrasound, if indicated, followed by biopsy. The intermediate lesions are suggested by skin thickening without presence of any highly suspicious features like irregular margins and microcalcifications. We have, in that case, we have to see if there is a prior studies available. If it is available, then we have to follow these patients for next at least 2 years. If there's not available, then we should these patients should undergo further diagnostic breast imaging. So coming to MRI, it's similar to the evaluations are similar to the breast incidentalomas found on CT scan. However, the incidence is lower than the CT scans, and the malignancy rate is also lower in case if they are found in MRI. Coming to the most common ones, the breast incidentalomas found in FDG PET, though they lack sensitivity in detecting small lesions, but they can be found found in some cases. Different breast cancers histotypes can present in a wide range of FDG avidity with infiltrating dark carcinoma histotypes showing a much higher FDG uptake in comparison to invasive lobular carcinoma. The prevalence is being the least as compared to CT scan and MRI being 0.4%, but having a highest risk of malignancy rate up to 55%. So this is the study which is showing if you, on the basis of SUV max, if you can detect whether the disease, whether the mass is benign or malignant. In the univariate analysis, they have found that SUV max is significant in between benign and malignant diseases, but in multivariate analysis, they only found that virus category was significant in between benign and malignant disease. So there's another study which is showing that there's no statistical significant correlation between SUV max and histology, whether it is less than 2.5 or more than 2.5. So this is my concluding slide to conclude, which is interesting to us as clinicians, that if it is detected on imaging done for other regions, like chest X-ray, 2D echo, Doppler, CT scan, MRI, or FDG PET, we should go ahead with clinical examination and a normal triple assessment, which we generally do for other cases. And if the benign pattern is found in the breast imaging, then age appropriate breast screening and follow-up should be done. If they are intermediate lesions, then it should be followed up according to the BIRADS category. If they are suspicious in the BIRADS category, like BIRADS 4 and 5, a tissue diagnosis is warranted, whether choroidal or FNAC. And if there's confirmed malignancy, then multidisciplinary breast pathway should be followed. Here to emphasize one point, that the overall management would depend on the primary malignant disease. If it is an advanced malignant disease and breast cancer is of low risk, then the further treatment and follow-up should be according to the primary malignant on basis of which FDG PET-CT was done. Thank you.
Thank you. If any question from floor?
This made the so-called incidental trauma in breast more common actually. Otherwise, before that, nobody used to pick up those things. So you have to be very careful in evaluating these patients, and timely must intervene. I mean, it's good outcome of introduction of new imaging. Most of the incidental mass, wherever it is located, they are all because of imaging is coming up. And in pituitary also there are incidental mass, all picked up because of this imaging. So for the next generation, I mean, to find to address these issues, especially pancreas as well as breast and adrenal, all these things. What are the basic workup you should do? For breast, it is easy. What for pancreas and for adrenal, it is little difficult to evaluate and reach at in conclusion. But we should be very careful about these things about the breast. But mammographical detected lesions cannot be treated as incidental of the breast. Am I right? If you're doing routine screening of breast cancer to mammography, if you detect something, I don't think that is classified as incidental mass.
Those
Am I right?
because we are screening for
Yes,
reason,
yes,
so that
that's right.
should be classified.
Good. I think we enjoyed all the presentation in this incidental mass session. You want to add anything else? Thank all the presenters as well as the audience to participate, as well as my co-chairs to join in the discussion.
Thank you all presenters for that for those insightful lectures. We will now be moving on to our next session, that is the podium presentation of the three posters. I will now be inviting Dr. Sabaratnam to the stage to brief about the next session.
Good afternoon, everyone. As the coordinator of a poster walk session, we had 25 posters evaluated by our faculty, international faculty from abroad, and they have given their detailed evaluation methods also. Now they have selected four posters, which will be presented for each paper will be presented for 4 minutes and 2 minutes discussion will be there. And neutral judges are scoring now also. So I will request the first presenter to come and start the presentation.
A very good afternoon, everyone. I'll be presenting objective assessment of vascular dysfunction in pheochromocytoma in paraganglioma patients and the reversal following curative surgery, a result of a prospective cohort study. I have no disclosure, and this study is accepted for publication in the Surgery Journal. Hypertension and cardiovascular changes are hallmark of pheochromocytoma and paraganglioma, and the cardiac changes are well documented, but vascular changes and its reversal following surgery is not well documented. So we aim to study the nature and extent of vascular changes and impaired vasodilatory response in PPGL patients using objective, non-invasive methodology and the reversal after alpha blockade and curative surgery. So it's a PheoCARD prospective study conducted at our institute for a period of 2 years from January 2023 to 24. Institutional Ethical Committee clearance was taken over and it is registered on clinicaltrials.gov.
We included 40 biochemically and histopathologically proven PPGL patients who, after adequate alpha blockade, underwent curative surgery, either in the form of open, robotic, or laparoscopic surgery. And the cure of hypercatecholism was documented by by 24-hour urinary fractionated metanephrine and non-metanephrine values, which were done 7 to 10 days post-operatively. We have taken two control groups, 20 each, having healthy volunteers and essential hypertensive patients who didn't have any comorbidities, which will confound our studies. And vascular function indices were measured in both the parameters. We have excluded all the patients who were on alpha blockade at the time of recruitment. So we assessed two parameters, endothelium dependent and independent indices. For endothelium dependent indices, we measured flow mediated vasodilation, where we took a brachial artery diameter at the baseline, and after inflating blood pressure cuff, due to reactive hyperemia, there is vasodilation, and we calculated FMD using the given formula. We did this vascular assessment at 5 point of time at diagnosis, 7 to 10 days of alpha blockade, 7 days post-operatively, 3 months and 6 months. And for control, only baseline was taken. Similarly, for endothelium independent or smooth muscle dependent indices, we gave the patient isosorbate dinitrate, and then we measured the brachial artery diameter after creating the reactive hyperemia. And we measured NMD, that is nitroglycerin mediated vasodilatory response, using the formula. And again, at the 5 point of time, the following parameters were taken. This shows how we have measured the FMD and how eventually using the blood pressure cuff and ISDN, the arterial diameter has raised. So coming to results, out of our 40 patients, 75% patients were hypertensive, with 6 patients had bilateral disease and 6 patients had paraganglioma. 40% of our patients underwent minimal invasive surgery, and the mean tumor dimension was 6.6. To note that all of our patients had cure of hypercatecholism post-surgery. Both the healthy controls and essential hypertensive were age and gender match, and FMD and NMD of PPGL patient was significantly low compared to healthy controls. Here we can see that the baseline was deranged of the PPGL patient as compared to our healthy control, which is 9 and 15 for the FMD and NMD, which has gradually rose from 5 and 10 to 7, 13, and reaching to 9 and 17, which is near the normal of our healthy controls. So, but the essential hypertensives have FMD, which is deranged, which is a normal finding. So coming to conclusion, this is a first of a kind study employing objective non-invasive vascular assessment, demonstrating the elevated circulating catecholamine levels in PPGL patients, which impair both the endothelium dependent and independent vasodilatory response, which eventually normalizes following the curative surgery and alpha block. Thank you.
Okay, so what do you aim to improve in the outcomes by doing this technique?
Thank you, sir. Basically, what we want to improve is a clinical outcome. As we know that pheochromocytoma patients who have vascular derangements will eventually lead to a cardiac morbidity and mortality, like cardiovascular diseases and cerebral ischemia, peripheral or end organ ischemia. If we know that because of this vascular changes this morbidity and mortality will be there in future, and this is reversed via the alpha blockade and curative surgery, we can initiate our treatment earlier.
Did you have any technical issues while actually performing the FMD?
Yes, this is a very operator and technical method, but it is a good thing that it is non-invasive. All this procedure was done by a single experienced cardiologist who is experienced in doing vascular and Doppler day in and day out. And we have devised this technique where we have kept the timing to a fixed constraint, and we have inflated the blood pressure cuff proximally. All these techniques were finally because of the outcome in which the FMD and NMD was done in the previous study. So we use this fixed technique to do by a single cardiologist.
Okay. Your single cardiologist performed all the 40 cases and this.
We basically our whole cardiology team was there behind this, but only the one student did all this.
Okay, thank you.
Thank you, sir.
Did the duration of a very good presentation, thank you. Did the duration of the pheochromocytoma before you diagnosed it or the hypertension that was existing, did it make a difference in the outcomes of your study? And were you using 24-hour urinary metanephrines and normetanephrines for your primary diagnosis as well? Because the post-surgery completion of the removal of the tumor was done by 24-hour urinary metanephrines. Thank you.
In our center, we did do a 24-hour urinary metanephrine, normetanephrine to evaluate pheochromocytoma pre-operatively and both post-operatively. Here in our study, all patients were cured of hypercatecholism, but 42.5% patients still had persistent hypertension. So the reason of this hypertension can be that they might have this disease for a longer period of time or due to some essential hypertension. So this might, though the FMD and NMD has improvised, and the patients still have hypertension. This shows that the effect is due to hypercatecholism, not due to hypertension per se. And for the duration of the disease, we don't know how long did that patient have these symptoms, because we started the evaluation as soon as within a week or two when they came up to us.
I will now invite the next presenter, Dr. Prashant Kumar Prishti.
Good afternoon all. I'll be presenting our study, ICBN sparing axillary dissection, a key to better sensory and motor recovery in breast cancer surgery. Disclosures, this is an unpublished study. Intercostobrachial nerve is a sensory nerve that is often transected during axillary dissection. Previous meta-analysis have shown sensory benefit with ICBN preservation. This is one of the first studies in which we are assessing both sensory and motor outcomes following ICBN preservation versus transection. Aim of the study was to assess whether ICBN preservation improves functional outcomes in terms of both sensory and motor after axillary dissection. This is a prospective randomized controlled trial at a tertiary care center. 160 breast cancer patients were recruited and randomized into preservation and transection group. Assessment was done at baseline and 6 months post-operatively. Sensory assessment was done using clinical examination as well as subjective assessment for hyposthesia, paresthesia, hyperesthesia, numeric pain score, and DN4 neuropathic pain scores were used. A range of motion of ipsilateral shoulder joint was used, was assessed using standard goniometer. Coming to the results, coming to the sensory outcomes, hyposthesia, hyperesthesia, and paresthesia were significantly less in the preservation group, as well as the mean numeric pain score and mean DN4 neuropathic pain score was also significantly lower in the preservation group. Coming to the range of motion, it was seen that 65.7% of patients in the preservation group had improved range of motion as compared to the ICBN transection group. And there was a 43.5% improvement in the range of motion at 6 months as compared to the transection group. To conclude, ICBN preservation significantly reduces sensory morbidity and neuropathic pain. Patients show superior post-operative shoulder mobility with ICBN preservation. Hence, nerve sparing axillary dissection should be adopted as standard practice in breast cancer surgery.
Okay, you did a review of the letter. I mean, it has been studied earlier and a lot of studies. What is the difference between the published literature and your outcome?
Sir, in the previous studies, they had not assessed, they had not focused on the motor outcomes. In our study, we had assessed the motor outcome as well.
Yeah, but in the sensory outcomes,
In the sensory outcomes, it's similar to the previously published meta-analysis.
So good presentation. So with regards to the shoulder mobility, you would have definitely done it in the preoperative setting as well,
yes,
and compared with the postoperative setting. So was there a significant difference that you found out?
Yes, the range of motion in both the groups, in the preservation group, there was significant improvement in range of motion, not from the baseline.
Exactly.
But,
so I'm not expecting that. So it's whether there was any deterioration in the group where you had to sacrifice the ICBM. Was that evident?
Yes. In the group where ICBN was sacrificed, there was decreased mobility in the ipsilateral shoulder down.
Yeah. Was that significant? That's the question.
Yeah, that was.
And routinely, when the ICBN is not involved, do we tend to go and sacrifice it? Probably not. That's how we usually operate, right?
Yes, sir, that is usually.
Yeah.
But if the axillary burden is more,
Exactly.
But surgeons generally tend to sacrifice ICBN for the ease of the surgery.
Right. Thank you.
Can I ask why do you, this is a sensory nerve, why do you think there's a motor benefit?
Because loss of sensation, a sensation is essential for neuromodulation. There have been studies that have shown that if there is loss of sensation, that can prohibit the neuromodulation that is essential for the motor movements. So that's right for that.
I invite the next presenter to the stage, Dr. Vajni.
Good afternoon, all. I'll be presenting my research paper, Surgical Ergonomics, Open Thyroid Surgery. I have no disclosures to make and the paper is not yet published. Surgeons face a variety of ergonomic challenges in the operating room, leading to a high prevalence of work-related musculoskeletal disorders in all surgical specialties, ranging from 66 to 94% in open surgeries. However, these injuries are rarely reported to the institutions, creating a culture of silent suffering. There are few reports suggesting that the otolaryngologist experience some of the highest rate of musculoskeletal symptoms, but similar data regarding the ergonomic issues in endocrine surgeon is very limited. So this study aims to analyze the surgical ergonomics by analyzing salivary enzymes, angle of bending, muscle strength analysis, and Rula score in operating and assistant surgeons performing hemithyroidectomy for benign thyroid disorders. For this study, we collected 32 paired salivary samples in salivary vacuotainers having no additives, and they were immediately sent to the lab for analysis. Centrifugation was carried out at 3000 rates per minute for 5 minutes. The supernatant was used to measure the LDH, CK, and AST level using a fully automated biochemistry analyzer by spectrophotometric method. We also measured hand grip of the subjects, the assistant and the operating surgeon before and after the surgery using this digital dynamometer. The angle of bending was also measured, and this angle of bending at arm, at the wrist and the elbow joint, at the trunk and neck joint was applied to this Rula worksheet to get a final Rula score. This is an illustrative example being carried out to calculate the Rula score for surgeon, which was 4, and for the assistant, the Rula score was 3.
There is also a very handy app by the name ErgoKit available in which we just have to enter the angle of bending at various angles and then we get the ruler score. Coming to the results of this study, of the 32 procedures performed, amongst all the operating surgeons, 2 were male and 6 were female. Amongst all the assistant surgeons, one were male and 7 were female. 32 paired salivary samples were collected and 31 procedures were done. Hemithyroidectomies were done for solitary thyroid nodule and 1 was done for a dominant nodule. Majority of the nodule belonged to TIRADS 2 and were benign on cytology. Coming to the results, we can see a significant rise in the CK values in the operating surgeon, which was 2 in the pre-surgery, and the median has risen to 9.5 in the post-surgery. Similarly, for assistant surgeon also, the CK values had increased from the pre-surgery median of 4 to post-surgery of 16, showing a significant physical workload. The AST and LDH values had also increased from a median of 5 in the operating surgeon to 18 in the after the surgery, and for assistant surgeon the AST had increased from 16 preoperatively to 34 post-operatively. Although the rise was more in operating surgeon, but the increase was significant in both the cohorts. LDH had also shown a significant increase in values post-operatively. When examining the hand grip, the operating surgeon, the decrease was only from 23 to 22, which was not a significant decrease. But when looking at the assistant surgeon, there was a significant decrease in the hand grip strength of the assistant surgeon, declining from 25 to 22. The median ruler score for operating surgeon was 4 and for assistant surgeon was 3. The ruler score usually ranges from 1 to 7. The greater the score, higher is the ergonomic risk. And the median ruler score being lesser in assistant surgeon, showing that the operating surgeon poses a greater ergonomic risk. The angle of bending was also higher in the operating surgeon in the tune of 75 degrees, and in the assistant surgeon it was 45 degrees. Now comparing both the cohorts, we can see that the CK, AST and LDH values were both comparable pre-operative and post-operative. Coming to the conclusion, this study highlighted that both assistant surgeon and operating surgeon pose significant ergonomic risk. However, the risk was more for assistant surgeon when examining the hand grip, but the salivary enzymes had increased in both. And also there is not much literature available regarding these ergonomic issues in endocrine surgeons. Therefore, larger multi-center studies will be required, and the concept of microbreak could provide a simple practical solution for that. And there are now societies coming up with guidelines and recommendations for surgical position training and surgical tool making that can help. Thank you.
Okay, that was interesting. So the technique of hemithyroidectomy, was it standardized single surgeon or was it multiple surgeons? Okay. And the assistant was doing the same kind of retraction and procedure was standardized in the whole group. Okay. It comparing to other studies that have been done, any other tests that you could have checked to measure stress levels in?
So the other studies which are available, they are mostly in the form of questionnaire. There's no such kind of studies are available. The salivary enzymes were measured in rugby players. So that was the first time it was done to look for the muscle strain. In our literature, for whatever surgeons we have performed, those were all questionnaire-based studies. So.
Good presentation. Thank you.
Thank you, Dr. Rajni. I call upon stage our next presenter, Dr. Zubair.
Good afternoon, everybody. I'm Dr. Zubair from Sher-e Kashmir Institute of Medical Sciences, Srinagar, and I'll be presenting our study of assessment of changing quality of life in patients with primary hyperparathyroidism after parathyroidectomy. So disclosure, no conflicting interests, and it has not been published yet. So methods, this was a prospective observational study in which 93 diagnosed PHPT patients were included, aged more than 18 years and who met the surgical criteria. Patients who were non-consenting, attrition to worker follow-up, and CKD patients were excluded. The objective was to assess the quality of life, changing quality of life in PHPT patients before and after parathyroidectomy using the SF36 questionnaire. So we did biochemical assessments, which include serum calcium, phosphate, albumin, and PTH levels pre and post-operatively at 3 month pre-operatively, then at 1 month post-operatively, and 3 months post-operatively. Quality of life measurement SF36 questionnaire was used, covering physical health and mental health domains pre and post-operatively at 1 month and 3 month intervals. So results, biochemical findings, there was a significant decrease in the serum calcium and PTH post-surgery with a significant p-value. And there was improvement in the quality of life domains, particularly physical health and mental health, which increased from 47.91 pre-op to 79.88 post-op, 3 months post-op. And mental health increased from 56 to 82.93, 3 months post-op. And there was notable improvements in vitality, bodily pain, and physical function. So most of the patients were female, 87% were female. There was a decrease in post-op calcium and PTH in all the patients. Most common symptoms among the patients were generalized body aches, along with fatigue and joint pain. And if you see the web radar or the spider web, then we can see that there was a improvement in all the domains, but more in the mental health and physical health domains. Conclusion, parathyroidectomy significantly enhances quality of life in PHPT patients across physical and mental health domains, supporting broad application of surgery in PHPT patients to enhance their overall well-being, in line with the existing literature that's already been published. Thank you.
How did you decide to choose this particular scoring system?
So it has been actually validated in Urdu. The Urdu is the most common language used there, so that's why you chose this SF36 questionnaire.
Okay. You're aware of the PASICA scoring system?
Yes, sir, but we didn't choose that.
Okay.
There was another one as well, PHP, quality of life, but that was not validated in Urdu.
In this population. Okay. Did you face any challenges in the data collection? That review didn't
Not
have
much.
any.
The follow-up is actually good there in our part.
Mhm.
So we didn't have any challenges there.
Okay, well done.
Very nice presentation. So, and did the translated to the local language, I'll agree, but the understanding of the questions was still straightforward.
Yeah, we actually chose our inclusion criteria included patients who were actually
Educational
literate
status
to
was
use.
taken into consideration, or
yeah.
one particular cutoff was there. And do you have a longer follow-up that you're planning? Because
yeah,
this,
we're planning a 1 year follow-up actually in these
yeah,
patients.
because this is
it's a very
similar
short
to the
follow-up,
to the data that is already existing. So at you will see improvement at say 3 months. Did you have an intervention in an earlier period also? Did you have a 1 month and a 3 month, or is just 0 and 3 months?
It was 1 and 3, but we at the end we chose just 3 months.
Right. So at 1 month post surgery, was there actually a significant difference?
Not
that they
much.
had?
There was not much significant difference at 1 month.
Thank you.
Thank you.
Congratulations to all the presenters. I will be calling upon stage Dr. Gaurav Agarwal, sir, to give the concluding remarks.
So we come to the end of this 16 postgraduate course in endocrine surgery, and I can only thank everyone who has contributed to organizing this course, contributed to the scientific deliberations, and at the end, I can request for some feedback from all of you how we can improve our courses for the future. We had some very interesting, thought-provoking discussion over the last 2.5 days. There are shortcomings. There's no doubt about it.
There are areas where we can improve, again, undoubtedly, and we would all request your feedback and criticism, which will help us improve for the future. The faculty of this course, for some of the delegates who are here in the hall, they all are here for their love for teaching. They've traveled on their own. We have this kind of course, and our department doesn't have funds to provide them travel support or take care of the travel. But yet, all of them have traveled from various places, including the international faculty that we have. I can't thank them enough for their kind gesture. I hope you had some nice memories made during these 2.5 days, as much as we have done. And you enjoyed some of the deliberations, interactions with the fellow faculty members and the delegates. The delegates and the students, particularly who have participated, thank you very much. You are the very reason why these courses are conducted or planned. So in future editions, I would love to see wider participation, more number of students and residents, trainees coming to our courses. How? Very difficult. We've been trying our best, but unfortunately, so far, we have had only very limited success in it. And finally, to my colleagues in the department and various other people who helped us organize this course, thank you very much. This has been like your baby for last many months. You have worked tirelessly, planned, replanned, and certainly have sacrificed a few other things to make this a priority. It is all worth when it comes to fruition. Like whatever we have achieved is only possible because of the hard work you all have put in. I would love to take a few names, but that's neither. I feel that will. I know all those who I'm addressing. They know that I am addressing them, and excluding a few names will be terrible. So that's why I'm not taking any names. So once again, thank you all very much for coming over here. And now we can have we have a few certificates and prizes to give away to the extraordinary participants who have been here, some travel awardees or grant awardees, the poster prize winners, the quiz winners. Dr. Sabha, are you ready with the? Okay, so come on.
Thank you, sir. Before moving on to the valedictory ceremony, I would like to congratulate all of our presenters. Each one of you has contributed to the academic richness of this conference, and your hard work has already added value to the scientific dialogue and inspired all of us. With this, I will now be inviting to the stage Dr. S.K. Mishra and Dr. Gaurav Agarwal to hand over the award for the travel grant winners. To support the participation of the resident doctors in PGES course, travel grant is being given in the form of grant certificate and a check of rupees 5,000 Indian rupees. Our first award winner is Dr. Apurva Shukla. Dr. Surbhi?
you.